Okay.
Hello. Good morning, good afternoon, good evening, dear vascular surgeons and hematology along the universe. I welcome you to the 7th webinar meeting titled Recent Advances in Imaging and Vascular Procedures. First, I would like to thank Survey Company for sponsoring this meeting, and I would like to introduce my co-moderator, Dr. Omar Farouk. Hello, Omar.
Hello, Professor Ayman.
I would like to thank our great speakers today, Professor Erwin Tonder from Netherlands, Professor Louis Kamning from the United States, and Professor Rashad Bishara from Egypt. Also, I would like to welcome our great panel, Professor Jean-Francois Hall from France, Professor Pierluigi Antoniani from Italy, Professor Ashkan Haj Shams from Emirates, Professor of Dimitrik from Turkey, and Professor Munir Nazal from United States. Welcome, and it's an honor to introduce our first speaker today, Professor Erwin Tonder from Germany and Netherlands. He is going to discuss a very interesting topic. Professor Erwin is a senior vascular consultant in Maastricht and Aachen University, Netherlands. He's going to discuss diagnostic criteria in May-Turner syndrome. Please, Professor Erwin, the mic is yours.
Thank you. Well, welcome everybody. I would just like to say that the title was Duplex Criteria for the May-Turner syndrome. And when we discuss the May-Turner, we have to ask ourselves, what is a May-Turner syndrome? And you have all the inexperienced and nurses and doctors coming in, and we generally explain, well, it's compression of the left in common iliac vein by the right common iliac artery, and then we get this compression against the lumbal corpus, and that's the May-Turner, and that's the simple explanation. However, when we talk about compression, we have to consider that compression is quite normal in the human body. And this picture, we can see that this is a transverse plane of the vena cava, and you can see that it's being squashed during breathing. Here, just below the heart, you can see the vena cava is also being squashed, not on one location, but on several locations. And this is normal. This is total occlusion sometimes of the vena cava without it being pathological. So compression is not as easy as one may think. And sometimes you can see here at the level of the splenic vein interacting with the level of the renal artery. And you can see what the effect is on the blood flow here, that you can see it becomes more echogenic, just as it becomes, the compression is active and releases. And you can see what the effect is on the fluid, on the blood itself. So definitely in this story, there's some compression, and this is in the transverse plane. And we talk about nicely shaped and commonly sized vessels, but the vena cava itself, and I'm taking this vena cava at the level of the liver, you can see that there's branches coming in, deforming the lumen. It's not just about tubing, that, you know, it's not as simplified as that. So this is at the level of the iliac vein and artery, just the level of the internal eye. You can see what the artery is doing to the vein. It's bouncing up and down. And we have to ask ourselves, you know, is this pathological or not? And then when we're looking at the transverse plane, you can see that there's, at moments during the systole, that there's total occlusion of the vein. Is this pathological or isn't it? And that's when we have to that's when we need the patient to explain what they are feeling. So let's get back, and when I'm asked nowadays, what is a May Turner, I always suggest, well, let's go back to the beginning and start when we start a story. Once upon a time, there were 430 cadavers, and that's what we were looking at, and that's what May, and I didn't look at, what May and Turner, or May and Turner, if you're from Germany, say it correctly. And what they did was they looked at 430 cadavers, and what they found was fibrotic material, which they called a spur, in 22% of the cases. So this initially was, they hypothesized that maybe this was due to external compression somehow. This was confirmed by Cockett in slightly less cases, 29 cases. And once again, we're talking about fibrous material, the fibrous stricture of the vein. And this is what we have to consider. We have to go back to the roots before we start talking purely about compression. In normal people, and this is a well-known article, you see Kibbe being quoted and referenced in many articles, many publications, who showed that in 24% of the cases that he was looking at, in 50 normal patients, and what he saw was that there was more than 50% compression at the level of the common iliac vein, and in 66% even had 25%. So compression is quite common and not unusual. This is an article from our own center, from Maastricht. Dr. van Vuren did a study with radio, and did 20 normal patients with no complaints whatsoever. And they found in this patient group, it's a small group, probably slightly underpowered, but what they found was 80% had angiographic signs positive for May Turner. And I want you to remember this article, because this will come back to this one later. And what are we telling our physicians about the May or May Turner syndrome? And this is what we say. We can use diagnostic tools. We can say we have phlebography. Plethysmography is quite good, but when you have a negative result from the plethysmographic examination looking at outflow, it doesn't say that you don't have compression. We have MRVs, computer CTs, which are used quite commonly. IVUS is not readily available to everybody. Not everybody has the IVUS. And duplex ultrasound. And sadly, in these two papers, when we are talking about duplex ultrasound, it's being said, no, well, it's very user dependent, and it's not quite sensitive, and it's not really, we should use it. It's cheap, it's commonly available, but really it's not that popular, which is, in my opinion, is quite sad, because I feel that duplex should be, in the proper hands when we're teaching each other the proper skills, should manage with duplex. But both papers recommended other examinations rather than the duplex. Well, Lowell's joined us tonight, and I'm saying, well, we talk about aspect ratio, and we can see what happens when a normal size vessel, we can see that the volume is nice, but once it starts going down to the 50% elliptical form, we can see that the volume decreases significantly. And then, as you've seen the movies of the vena cava, you can say, well, sometimes the vena cava even has this shape, and the compression on the iliac vein was even this shape. So you can see that there's a total flow stop, theoretically, even for a slight instance. And then we have to ask ourselves, what is a pathological May Turner syndrome? And this was a nice paper done in the Davis group. And what they were saying, okay, well, May Turner, yes, what are the criteria? Well, we have, and once again, he mentioned, yes, compression, it could be 30%, 50%, it could be 70%. When we have pelvic collaterals, we should be looking for, not just looking at the point of compression, we should be looking at other things. When there's a velocity ratio, of, like in the arterial world, when we're looking at stenotic lesions, and we could say when we have a velocity ratio of 2.5 times the velocity, then we're talking about a significant lesion. And then we could talk about pressure gradients. And if you look at the pressure gradient during rest, it's only 2 millimeters of mercury, which is quite small. And after exercise, you could say 3 millimeters of mercury. And we need instruments, if you're talking about instruments available on the market to detect these kind of pressure changes in a human body whose pressure is changing consistently. these are quite small values to detect, so it's quite difficult. So when we come to compression, and that's when I say this is the great advantage of duplex ultrasound. You have the patient lying down supine, and you can compare the distance between the vertebral corpus and the right iliac, common iliac artery, and then you can put the patient upright, and you can see, lo and behold, that the compression disappears. So in the duplex world, you have patient positioning, which is quite common. This is a movie of the patient coming from an upright position going towards a supine position. I just want to see the effect and just watch what happens to the lumen. But the more interesting thing is here the echogenicity of the blood at this plane, at this part here in the vena cava. You can see it becoming echogenic, and this is the effect of compression. So you can actually see the blood becoming more compact due to the compression from going upright. And this is in a supine position. You would say, yes, this patient has a May-Turner. And then we have to say, is it a syndrome or anatomy, depending on what kind of complaints the patient is presenting. But this is the interesting thing, that is that you can actually see the blood becoming more echogenic, as it sort of looks as if, you know, if you're looking at thrombus, you would probably believe, hey, it's becoming a thrombus at that very moment. It's not true. Then we're looking at the form. It's not the compression. This is the longitudinal plane of the common iliac artery, and you can see what kind of shape it can give against in the corpus vertebrae. This is the L5, and you can see that it's being squashed completely. And then we have to say, yes, we're not talking about nice shapes, but this is the moment that you can say, well, is this really, this is the moment that flow just stops. We can do other tricks, like what I call a bit of a trampoline technique, is that you're giving additional compression. You can see if this vein dilates, if it's distends further once you've occluded really, so if it distends more, then you know that the compression is not that bad, because if the compression was close to an occlusion, it would be permanently dilated. But as you see, you can see it distends slightly, and when you let go, the blood flow. But this distance between the corpus vertebrae, this is a very small distance. And then you say, okay, well, if you put the patient upright, would you see this kind of pattern? And this is the same patient in an upright position. You can see that the distance in the transverse plane increases significantly. And lo and behold, when you do a cross-sectional area, this is the longitudinal plane of the artery again, and it's the transverse of the left common iliac vein. And when you're looking at the surface area, sorry for the German, because this is one that was taken in Aachen, you can see that you're talking about surface area, so 1.8 square centimeters. Now, generally, if you're looking at stents, you will come across stents giving you about 1 to 1.2 square centimeters. So if you're going to put a stent in it, you would probably put an undersized stent if you didn't put the patient upright, if you're only looking at compression in a supine area. And this is, once again, this is what I recommend when people are using ultrasound. Always put the patient upright and make sure that you get the right parameters and dimensions. Of course, if you have a patient in a supine position giving you these kind of distances, and it looks normal, this looks okay, that's similar to the image that I've just shown you, and then you put the patient upright, and then the distance doesn't increase, then there must be something wrong. That means that this flexibility is gone. And then you say, if it doesn't move that much, then you can use color to say, and then you can see, lo and behold, you have wall thickening. And this is what we should be looking at. We should be far more critical in our ultrasound examination and scrutiny, and trying to sort of assess more carefully and really play with the ultrasound settings to get more accurate diagnosis. And another thing that you should be looking at is the collateral flow. This is the external iliac vein on the left side, and you can see that the flow is going down into the internal iliac. This means that there's reverse flow, more reverse flow going into the internal iliac vein. The blood flow is disappearing and choosing to the long route through the pelvic region rather than going through this slightly fibrotic common iliac vein. And these are telltale signs. These are the signs that we should be looking for on a hemodynamic sense, and not just looking at the morphology and saying, okay, where is the blood going to? And coming back to this article that was published in Maastricht, there was quite an interesting correspondence that got mentioned, and they're saying, and sadly, my own center, where we were showing and demonstrating that we could put patients upright, failed to see this because this was the question that, well, you know, should we be relying on supine imaging? Shouldn't we put, you know, be looking at other things? And they said, well, the whole idea of the May-Turner was actually defibrotic material. You should be looking for spur-like projections, wall damage, and support vessel. And they agreed to the fact that maybe we should be doing, and not relying on the supine imaging, but sadly, all modern imaging techniques are really performed in a supine position, like MRV, CTs, everything's done in a lying position. And they failed to mention that, you know, you can put patients upright with duplex. And that's why I'm an advocate for duplex. I believe that you should use the duplex in a proper way with the proper skills, and we'll get more, a more accurate picture of what really would be a May-Turner. And staying with ultrasound, and people ask, what is the role of IVUS? Nice paper here done by Byrne. We looked at 34 patients and said, well, you know, if you're using IVUS, and you're using IVUS not just to look at the lumen shape, but rather you should look for the abnormalities in a more critical sense, and you will find out that, you know, in this case, he had 34 patients, of which 61% had an abnormality. Whereas in the flood, if you read the article, he said, well, there was only, you know, of these 61%, only a third showed any abnormality on a phlebography. 33% had venous narrowing, and if you're talking about non-stenotic lesions without any kind of stenosis, they could still see webs, pleats, wall thickening, increased wall echogenicity. So these are things that we should be looking at with the IVUS, if you're using IVUS, if you have IVUS available. And they concluded saying, yes, even if you're using IVUS, we still don't have clearly defined criteria. So that is a field of research that requires exploration and more attention. However, if we can focus on fibrotic lesions. Having said this, and I thought, Eureka, we have found that, you know, we should be looking at stenotic lesions with duplex, putting patients upright, and if we don't have these fibrotic pictures, then it's not really a May-Turner. However, there are several cases where patients are suffering. They're waking up at night. They have pain in their legs. It's swollen in the morning when they want to get up. They claim, and these are sometimes young patients, saying they have impairing complaints. They can't get up. They're not up and active straight away. And sometimes you find that these patients have had an idiopathic DVT of the left leg. And in these cases, and these are the unusual cases, where you're looking with the ultrasound, you can put them upright. You can say, well, I can see that typically when they're supine, you can see the compression here of the right common iliac on the left common. You can see the flattened, nearly zero area of the lumen of the left common iliac. And when you put them upright, yes, the distance is increased significantly from 0.1 to 0.5 approximately, and the area is not that bad. You say it's close to 1. Should I put a stent in here? We get these discussions, you know, should we do it? And then we're looking at the reverse flow and collaterals, and this is the same patient, and you can see, yes, this flow in small branches. I know that Professor U is joining us, and he has great road mapping, and that's what we should be looking at. Where's the flow going to? Is the internal iliac, also reverse flow going into the pelvic region, and we need to know our anatomy to really, and we can, and I can say that if we do know our anatomy, we tend to see more with our duplex ultrasound. This is just an example. This is the same young patient with the MRV. And then when you're saying to any average radiologist, say, yes, well, you know, it's not just a compression. We're looking for collaterals. Let's join the Davis group, and we're saying, do we see any significant collaterals? We do see the compression of the Turner. You can see it through transverse is the right common iliac arch, and here's the left common iliac arch, and you can see the vein looks completely flattened. And interestingly, this patient not only had a flattened common iliac, but if you're looking at this level, and I'm saying at this level, you can see that there's the left renal vein is going behind the aorta, and also there you can talk about saying not only the May-Turner compression point, but there's also a sort of behind the aorta. It also seems compressed, and this is what we have to look at. We should not just focus on the common iliac vein when we're talking about a May-Turner syndrome. We should be doing a complete assessment of starting with the vena cava, looking for the potential nutcracker, and excluding the complete drainage of the left leg and not just focus on it. This is the same patient again. How did this patient get treated? After a lot of discussion, it was decided to give a stent, and you can see this is pre-stenting. You can see what happens to the flow. You can see that there's the internal iliac vein is here, and you can see the crossover towards the contralateral side of your flow. There's no flow going through the common iliac vein into the caval vein, and then after, and you can see once all these collaterals, these are the side, yes, you know, you can see there's significant pressure there, so there's no outflow of the common line. And then after stenting, and this is a sinus obliquus, a large stent, because based on the cross-sectional area, we say we don't want any stent migration, so you need to do a large stent. And you can probably see, if you look at the lumen carefully, you can see that the lumen here is quite small compared to the stent lumen, but that's to make sure that the stent doesn't migrate, because we have had cases based on if you're just doing supine assessment with all the other modalities, and I believe that you really need the ultrasound to confirm that your stent size that you want to use is correct. So when we do put in the stent, this is the cross-sectional area of the stent, you can see that there's a surface area of nearly 1.5 square centimeters, which is very large for this young lady. It looked good after, this was the duplex before discharge, and you can see that there's a large diameters being used, so it's a large stent to make sure that there's no stent migration. And lo and behold, her complaints disappeared. So she didn't stay awake at night anymore. And if you're talking about Mater, you cannot, we see a lot of publications talk about virtue of stride, and we should consider what are we looking really at. We're looking at the flow, and this is what we can do with duplex, and we can look at the vein as a conduit. And the nice thing about duplex is that you don't just do it in a supine position. Contrary to all the other image modalities, we can put the patient upright, and we should do. This should be mandatory. We should not just depend on supine diagnostics. And then, of course, with the duplex, we cannot really look at the hypercoagulability of the blood, but this is what we should be looking at. We should be saying, where is this blood going to? Of course, there are limitations to our duplex. And if people ask me, what is the duplex protocol that you should use? And I tell them, well, if you've read this article, this is the protocol. And I find the title is, sadly, it's been related to the pelvic congestion syndrome, and really should be, you know, this should be the standard protocol as it assesses the complete pelvic region as well as the escape points towards the legs for varicosities. It gives you a complete roadmap. And I think this is the paper that everybody should read on how to do the duplex ultrasound. And in this paper, sadly, there's only one just short mention of the fact that maybe patients should be put up in a supine position. And I believe that the authors found, you know, that they felt maybe they were putting people under pressure, but I think it should be mandatory. I think they should have really put a hard suggestion in this paper, because they've got a brilliant protocol looking at it. And I think, and if you want to get trained, training is there. François Houle has a yearly training program in Paris. I think that, you know, that's a really good one to go to for this kind of anatomical knowledge to understand it. We really need this. And we should not just do treat a May Turner as a very simple, the most primitive, the most easiest class to put in the stent compared to the post-traumatic syndrome patients. In conclusion, I would say that people should look at the ultrasound skills. Do not be shy. Go to training and get these skills. It's not just about compression when we're talking about May Turner, and it's supine versus upright, and not only just to see if there's really true compression, but think ahead. If you are considering putting in a stent, help each other, say, okay, I can give you some indication. There have been cases, I know from personal experience, that even though you warn them and they don't trust the ultrasound, what happens that the stent disappears and say, oh, we didn't put in the right size. So I keep warning people, use the ultrasound to help. It's not the standard, I know. I don't see very many publications telling you what kind of size stent to put in on the basis of the duplex findings, but it should be additional, complementary to all the other modalities being used. Hemodynamic mapping, find out where is the flow going. Is this really related to the complaints that the patients are describing? And I say, in the complaints, treat the complaints and not the images. No matter how nice or how convincing the images are, you must ask the patient again and again and again and assess their complaints accurately and say, you know, and if you're in doubt, a multidisciplinary approach, not just, you never just trust the images and treat the images and say, well, I have found the cause of your complaint. So it's not that easy. Thank you very much.
Thank you. Thank you, Dr. Arwan. It was a very nice lecture, and I think we all enriched by this data. Before we start our discussion, let me welcome Dr. Eduardo Ramicino from Brazil and Dr. Jamal Hubballah from Lebanon, and they joined our panel. Welcome to the webinar session. Now I think we have to make some discussion. Let me ask Dr. Antoniani, do you have a comment for Dr. Erwin?
Microphone. Okay, it's very interesting presentation, and thank you. It's very, very good. Now we discussed just last year with other colleagues about the chronic venous, abdominal chronic venous disorders, to put together all the situations such as the Metternich syndrome, Nutcracker syndrome, and pelvic congestion syndrome, to put all together and to define possible the common line of evaluation. What is the difference between the other syndromes and the specific Metternich syndrome from the diagnostic point of view? Ultrasound, of course.
Good point. Yes, Dr. Arnold, please.
It's a complete picture that way, because I forgot to mention that when you're doing your assessment, you should approach it as a pelvic congestion syndrome. And I know that there's discussion about the term pelvic congestion syndrome, if that's the correct term to use. We see a lot of papers about chronic pelvic pain. It's quite difficult, but I believe that if you're looking at, or if you want to treat iliac lesions, we should be looking at the complete roadmap, and no matter what you call it. So I would say that this multidisciplinary group that was formed to look at the pelvic congestion syndrome was on the right track. I have several conversations with Mauro Wickling, who is from the Netherlands, who's talking about this, and he's challenging me, because I said, well, we have to get the right terminology, like what we have done already with venous disease. And this is a field that we really need to focus our attention on, because we are fragmented and everybody has their own approach. And I think we should try and achieve the highest level possible. And it involves training as well, because a lot of people believe that they can't see things. They do, see it every day. But it should be, I think the training is not only the terminology, but the training should also be given.
Great. Dr. Ul,
yes.
Please.
Yes. Thank you, Erwin. Very nice talk and very nice images. I have one remark and one question. The remark is regarding the positional. You show very well that it is positional compression. It's not constant compression. And this is mostly important because you need to treat the symptoms and not the image. So this is, you said that is very important. And this position is related to the spine. This explains why you have twice more Metternich syndrome in a female, because you have the spine, the lumbar spine is different. So it's the same for Nutcracker syndrome. So second, I have a question for Erwin. There is a paper which will be published very shortly in European Journal regarding the variations of the Metternich, because you show us mainly the classical Metternich, but you have a lot of anatomical variations, which are related to, of course, to anatomy of the arteries. And in this paper, I was a reviewer recently, it showed very interesting things, that you have a partial compression of the vena cava. It's more than half of the cases. You have a complete compression of vena cava in about 10% of the cases, and you have multiple compression in like something like 20% of the cases. So what about this is more complicated to display and to diagnose in US, because you see it's a complex anatomy with multiple compression. Don't you think in this case imaging could be very interesting in complementary to echo investigation.
Certainly.
Very nice remark. I think that the position is very important to put in mind. May I ask Dr. Eduardo from Brazil, you have many cases of May-Turner syndrome, and you have comment for this protocol?
Let me just, yeah, I'm opening my video. Can you see me?
Yeah.
Can you see me? Just give me a second. Well, we are
Now,
very conservative. Yeah, I tend to be very conservative with the May-Turner syndrome. You know, we have a lot of young vascular surgeons. They love to stent it a lot. And we're learning how to deal with these protocols, and we're paying extreme attention to treat these patients only with very high volume of symptoms. I'm not a ultrasonographist, I'm a vascular surgeon. So I trust on my sonographer to provide me the proper diagnosis, but we tend to treat very few patients, very, very few patients, particularly young lady. I have a feeling as a surgeon that we can see these images very frequently, particularly in obese ladies. But as I told you, I'm not an ultrasonographist.
Great.
Yes.
Dr. Afak, the situation differs in Ankara?
Thank you very much, Erwin. This is very good lecture. We know that your group works especially for the deep venous system. And also in our groups, Dr. Suat, when he began to work in the Maastricht group, especially with the ultrasonography together, Erwin, after then this time, approximately last 5 years, we routinely check the young ladies, especially after the pregnancy period, if there is the problem, such as the swollen and the pain, subjective or objective, it doesn't matter. We check the abdominal ultrasonography to the all of the compression, nutcracker or May-Turner pelvic congestion. We perform routinely, and I think the main topic is the misdiagnostic, mistreatment. And so in this point, I ask a question to the Erwin. How about the timing of the treatment of these patients, May-Turner patients? When and which patient? Thank you.
Dr. Erwin?
Yes. Well, the fibrotic lesions, if they're very clear, and generally when we see fibrotic lesions, then we look at the patient really not as a May-Turner patient, but more rather as a post-thrombotic syndrome patient, if they have the symptoms complying with the post-thrombotic syndrome. The young ladies, we used to stent far more often, but now we've become, as has been stated earlier, a rather more conservative approach. We wouldn't stent as easily as unless it's very convincing. And let's say in Aachen, I could say that we have long discussions before anybody receives a stent. Dr. Homan Jadi has a lot of experience in assessing and takes his time before placing any kind of stent. So the rate of stenting has gone down in the European Venous Center, which was started up with Professor Wittens. So the May-Turner category is one that's reduced drastically in recently, because we are not convinced of the relationship between what we're seeing as just the compression, the iliac compression. That's just a simple approach. It's far more complex. So we're looking at a complete picture, and it takes time. It takes, sometimes you have patients coming in and out, and they have to convince us that the complaints are so bad that it will require a stent to relieve them. And then we have to follow them up. We warn them that the stent, that they might be disappointed because our stents, we have to also realize, our stents are not as good as we would like to believe, even in the case of May-Turner. The situation with the the post-thrombotic syndromes, we have a large acceptability because people are far more desperate and you have far clearer complaints that you would put in a stent to give them some kind of resolvement. But in the May-Turner, we're very resolved. These are generally young patients, as you say, and as Jean-François pointed out, these are young, generally more ladies, and after pregnancies, the pelvic structures change, and then you have to sometimes wait. You have to say it takes time. Maybe sometimes problems will resolve itself.
Okay, this is nice. Dr. Jamal Hoballa from Lebanon wants to ask you a question, Dr. Arwen. Please, Dr. Jamal.
Sure. Well, congratulations again on a very nice presentation. I think the comment you made at the end about treating the patient and not the images is very essential, because we often see compression without any symptoms in some patients incidentally. And that's why it's really very important to make sure that we are treating the symptoms and not just the imaging. My question to you is really, do you have any special tips on preparing the patient prior to the sonographic evaluation? Do you keep them MPO? Do you give them any kind of Simethicone or any kind of medication so that you don't have a lot of bowel gas obstructing the views?
No, I don't have any. I know that some people prefer to give some kind of preparation, but I don't. The only thing I ask the patients to do is not to drink any carbonated drinks. Some young people have a tendency to just go and buy a can of soft drinks and they come in full of gas. Because generally, under normal circumstances, you're able, as ultrasound, using the transducer, you can massage away the bowel gas. It will stay away, give you enough time. And I saw one of the questions about, do you not have any kind, as a sonographer, aren't you the one causing the compression at this point? Certainly, that's why I showed you this trampoline technique, that you're deliberately giving compression and relieving compression to give them. But there's no, in my case, I don't give them any kind of particular preparation. They can come in. I also suggested, I just asked them, do not drink any carbonated drinks. That's all.
Great. How about Valsalva maneuver during compression? Have you had any kind of findings with that?
Yes, I've tried that. It's possible, but extremely difficult. And we have to realize, basically, I like the Valsalva only in the sense that when you're looking at neoviruses or neovascularization in the groin region, because Valsalva is not really a physiological, natural operation. It will distend the vein. It has limitations. Some patients can't do it properly, and as you're trying to maintain the image, you will find that the stomach wall will displace your transducer in such a way that by the time they've managed to hold their breath, that you've repositioned your transducer, that you've lost the window of opportunity of properly assessing the point that you would like to see. So Valsalva is possible, but I would not use it. I'd rather put the patient upright and look at an upright position. That's physiological.
Before I leave the mic to Omar, because I see he has a lot of questions, we want to take a final comment from Dr. Kapnik, and then I'll go to Omar.
Thank you very much. Erwin was brilliant. In your cohort of patients that have obstruction, if the obstruction is relieved, do you see superficial venous reflux abating or stopping?
No, not always. Depends where it comes from. Sometimes from the...
Great, I'm talking about obstruction of the iliac. If you relieve the iliac, do you see saphenous reflux stopping?
The saphenous reflux, that's an interesting question though, because if you really have bad iliac compression, you can know that you'll get a natural crossover from the groin to groin generally. And we're quite reserved to take away, if there's any reflux, we're very careful to say, was this a collateral? Just in case, if the stent was to occlude, if you're going to remove these varicosities, and they're not real I keep on instructing patients saying, be careful to call these are not varicosities. Call them collaterals. These are your reserve escape routes. You don't want just to remove them, as we are not certain. And I say in the case of the May Turner patients, that the patency rates are very good. You're seeing 96% patency rates. So the stents are maintaining, and then you have them on you're giving anticoagulation in some cases, depending on what kind of profile they have, for at least half a year, and then you hold your breath and say, okay, now you can stop taking anticoagulation, and you hope the stent will stay. And then I certainly wouldn't recommend any kind of varicosities being removed in the initial 6 months to a year to warn the patient, say, be very careful to remove these. But they tend to go down in size. But if you're really critical with your duplex, you will still see reflux in the saphenous femoral junction region. It's going somewhere, and it will go into the pudendal branches. Sometimes it will descend into the accessory and go up again on the outside of the abdominal and into the epigastric region. And you say, yes, well, this is a round way trip, or into the perineal area and into the perineum, and then you say, well, okay, let's leave these for a while. But after a while, when they've had it, and they go shopping in the Netherlands, you see a lot of patients who've received stents, they've got rid of it, and then they start they say, look, now it's time to to be beautiful as well as I've had symptom relief, and you see them go shopping, and they will get somebody to treat their varicosities.
Thank you.
Okay, take over, Omar.
Okay, I think Professor Ashgan have a quick comment or question. Professor Ashgan?
Hi, thank you for the nice lecture. I had two comments. One of the comments is, unfortunately, our colleagues radiologists, that most of the time if they reach those patients, they are very fast in putting a stand on and sending the patient back. What is the idea of your idea or your approach toward different age type patients? So as you mentioned before, a young patient who are in a more possibility of having continuous pregnancy after each other, or those that has a little bit of more age and they are in less possibilities of getting pregnancy. So are you more reluctant in stanting those patients or no? Or do you have any other protocol for that?
Professor Erwin?
Sorry, I missed the part of your voice disappeared for part of your question. So something about being elective and related to age is what I sort of caught the drift.
Yeah.
You're saying, would you avoid stenting if somebody was young enough to be pregnant again?
And again, like 5 more times.
Well, we have experiences, and I know that Niels Beckhardt did a study in Scandinavia where they said, pregnancy has no influence on stent patency. But I would, be careful. I would be careful in saying if they have, because we always ask them, do you want to have, you want to have more children? There's no rush. We don't have to rush into these kind of things. The stent is not going to, you don't need to stent today. You could have that if necessary, maybe in the second pregnancy, the situation completely change. We have no crystal ball on our table. We don't know what's going to happen in the future. So I was just say, unless they really have complaints, unless you know what you want to resolve, and the complaints are serious, then you should contemplate stenting.
Okay, thank you very much. We have plenty of questions. I think one of the big advantage of this platform that it is an interactive. So I have a total of 16 questions, and they can overpower the question, which means if the question is very strong, it will become overpowered. So the most powered question, which is multiplied 6 times, was by Dr. Omar Al-Dakhan. He said, Mr. Erwin, in Europe, are overstenting is a problem or not?
You're talking about overstenting of the contralateral common iliac vein? Is that what you mean by overstenting?
We speak about overstenting to May-Turner syndrome if there is no hemodynamic evidence that it is really is the cause of the patient's symptom. Is overstenting is really available in or present in Europe?
No, I think maybe several years ago when it was sort of coming into, but people have become far more careful. I think it's thanks to these kind of platforms and congresses and the warnings to people receiving, they're taking heed of these warnings and not being driven or tempted to use any kind of stents, that they're becoming far more careful, more critical. So I would say today, interventional radiologists and surgeons are far more hesitant and do realize that they have to look at many more aspects. And as you say, emphasize, are you really going to solve the patient complaints? If you can't guarantee it, don't do it. You know, if you're uncertain, don't do it.
Yeah. Okay, the second question by one of our very famous angiologists, Professor Wasila Taha. She said, great presentation. Duplex is operator dependent. How we could avoid iatrogenic compression by operator? Do you repeat on supine and erect position?
Yes, always. Never perform your duplex ultrasound in just one position. So, and people say to me, do you have time for this? If you practice, you will have imaging very quickly. Also, your approach, where you place the transducer is quite important. People are amazed at why are you placing the transducer at the lower right abdomen when you're trying to look at the left common iliac vein. That's using your anatomical knowledge, looking for the best planes to avoid giving compression. I do not place the transducer at the level of the navel because people tend to believe that that's the shortest route towards what you want to picture. No, you have to think three-dimensional and you have to place transducer in strategic places. And you will find that you get very nice imaging. And if you practice, you will see that the imaging that you're getting, you will, within a quarter of an hour, you will have seen what you want to have seen in a supine and in an upright position. You target what you want to see. You're quick, and people are quite amazed at if you do this routinely, and it's training, and it's just improving your skills. And I think it's just going to courses, getting these tricks, and you will become more comfortable. I think Dr. Ufuk knows Suat Ganji, who spent some time in Maastricht. He is very good, and he's for a surgeon. And I say a lot of people saying I'm a surgeon, I don't do ultrasonography. He's a surgeon who does ultrasonography. I said, you know, if you're a bit shy as a surgeon, say, can I do ultrasonography? Go to Dr. Suat Ganji as a surgeon. He will tell you how he does it as a surgeon to give you the tricks from a surgical perspective. You know?
Okay. Another question from one of the most eminent vascular surgeon in Bahrain, Professor Zafir Kamal. He said, wonderful presentation, Professor Erwin. What is the most practical and reliable method to diagnose MTS in standard service with limited availability of high-end equipment? So if you don't have a high-end machine, a high-end duplex machine, what do you say to the radiographer to do?
I can tell you that I've shown you images tonight of what people consider portable machines, and the portable machines today are as good as any high-end machines. It depends on how you program your machines. The presets are important, the right kind of transducers that you're on the machines. You don't need high-end machines. I can tell you, you could do it with the modern portable machines are good enough.
Okay, this is question come to my mind. If you have one test to do, Professor Erwin, and you have a patient with possible May-Turner syndrome, do you prefer to do duplex or ascending venography? Which one you can rely your treatment? If you have a choice of choosing one.
Well, for me, that's a no-brainer. I would use the ultrasound.
Okay, you can judge the amount of collateral, the amount of flow with the peak systolic. You don't need to see the ascending venography picture with the delayed filling, with filling of collateral contralateral side going up.
I can tell you that we can simulate anything that the phlebography can show you with duplex ultrasound. If you're skilled enough, I can show. We consistently we're challenging. You know, you have to sort of compete with MRV images. You have to compete with the phlebography. It's not really competing. You're complementing each other, and you have to say, okay, is it being verified? You have to verify. We need at least two modalities convincingly verifying each other and saying, these are really true findings. This is not second guessing. It's not the ultrasound saying one thing and the phlebography saying another. If they verify each other, then you know that you're on the right track. And if the MRV helps you in this with, and we're still at the primitive phase of the MRV. We'll have MRVs. It's, you know, if you write the right protocols, we're going to be talking about flow. We're going to have MRVs in the future where we can perform scans in an upright position. You know, this is all coming, but we need the basic information. And I tell you that I think that the duplex ultrasound is the cheapest and most available and the easiest way of doing it. Okay. We'll give you the roadmap for the future other modalities.
Okay, I will take one last question from Professor Dr. Ahmed Gawish. He's one of our 250 attendees. He's one of the most eminent venous interventionists in Egypt. And now he's will open his mic and he comes to the panelists. You can ask your question, Professor Ahmed.
Thank you, Dr. Omar. I hope you can hear me.
Yes, we can hear you very well. Go ahead.
Great. Thank you, Dr. Emmer, for this very interesting presentation and very controversial and very exciting topic about May Thurner. I have to say we started investigating the iliac vein compression since 2008. So it's now 12 years we've been doing CT venography in order to diagnose these cases. And one thing I would like to highlight is that when we're talking about compression, it's not the plain compression we're talking about. What we found is that it's the impeded venous drainage that follows the compression that affects the patients. So the thing is...
Yes, we seem to have lost voice a bit.
Oh, hello? Hello?
Yes, we can hear you now. You can ask your question.
Yes. Yeah. I mean, it's when needed to distend the vein that actually when the May Thurner comes in action and it impedes the drainage when it's needed to increase. So I think the duplex, or whether you see the compression by duplex or CT or MRV, the idea is that we must have some provocation if the vein can dilate. As you showed us in your presentation, that with respiration you can have some compression of the IVC, but when it needs to be dilated to increase the drainage during walking or something, that's another issue. The thing is that the challenging part about diagnosing May Thurner still relies mainly on the last line of your presentation about the symptoms. I fully agree that it has to be, whether you treat or not, based on the symptoms of the patients. I have a question on that. We have been doing it, and I want to have your insight on that. That we usually give patients when we have high suspicion for May Thurner, and we do CT venography, and we find that compression. We put our patients on a therapeutic test with venotonics that improve the symptoms of the heaviness, the swelling, and the edema. So we give Daflon, which is micronized flavonoids for the patient for 3 weeks. And when the patient have relief of symptoms, actually the one symptom that does not improve using Daflon is usually the venous claudication. So when we have the patient having venous claudication that is persistent after 3 weeks of medical therapy, we are now sure that he will improve with stenting. And that's the policy we have been doing during the past year to select our patients. What do you think about that policy?
Well, I hope you're going to publish your findings.
Okay.
That's a nice, sweetest answer possible. Yes, that's true. Okay, thank you very much for this interactive session, and we'll go back again to Professor Ayman.
Thank you, Omar. Thank you, everyone. It was a very nice interactive session. Thank you very much. Now, I'm honored to introduce our great speaker, Professor Lowell Kabnik. He's a vascular consultant at Atlantic Health System. Dr. Lowell was the vice president of the American Venous Forum and he is the he is the past president of American Venous Forum, and now he is the vice president of the International Union of Phlebology and associate editor of Journal of Phlebology. Dr. Lowell Kamnick will going to talk about the endothermal heat-induced thrombosis. What do we want to know and more? Please, Dr. Lowell.
Thank you very much for the opportunity. Thank you, Dr. Ayman, and thank you, Dr. Omar. And it gives me great privilege to talk about, about 19 years of what I've been looking at in terms of endothermal heat-induced thrombosis. So I did my first ablation in using RF in 1999 and have been doing laser and RF. I have no conflicts with this presentation. So what I want to do is look at where we were before and 10 years after. So if we look at some of the literature in 2002, there were starting to be some questions about DVT. At that point, we weren't quite sure what we were looking at in terms of thrombus propagation. But we looked at registry data from Venous Medical, and what we found was that out of 286 limbs, there was a 1% DVT rate or thrombus propagation into the great Saphenous vein. Then some more questions came, and we started to look at some of our data. Dr. Merchant, Dr. Kistner, and myself put together our series. And if you can look at this, we had 5 cases, excuse me for a minute. We had 5 cases out of 1,150 that had DVT or 0.4% incidence. They were all asymptomatic, and they were found within 72 hours of a planned surveillance by duplex ultrasound. Interestingly enough, 4 out of the 5 cases were treated with thrombectomy. I was the only lone person there. I had 1 case, and I treated it with low molecular weight heparin until it disappeared. So I'm not sure I even understood what I was doing at that point. And the reference data for DVT for ligation stripping in a series is anywhere between 0.15% and 1.8%. So in 2004, at the American Venous Forum, Dr. Asher and Dr. Hingorani again echoed the problem of this entity. And they were worried about DVT after RF ablation of the great Saphenous vein, a word of caution. And in their early study, you could see that there were 73 limbs with this DVT rate of 16%. And when we finally looked at their publication, we understood that there was a beginning series, and they had a high comorbid area in terms of probably consideration. And then, interestingly enough, in 2005, our colleague Peter Glowicki looked at extension of saphenous thrombus into the femoral vein, a potential complication of new endovenous ablation techniques. And at the Mayo Clinic, they had 56 limbs with a 7.7% thrombus into the common femoral. And he even put a filter in 1 case and did a thrombectomy. But what he did understand was that at 4 weeks, this entity seemed to disappear. So one of us, myself, chose low molecular weight heparin, and he made the discovery that at 4 weeks, this entity seemed to disappear. So this was something that was interesting to me, and in 3 different institutions in Miami, in Italy, and in the United States, we put together some data and retrospectively reviewed what this thrombus propagation was, or better known then as DVT, and later changed to endothermal heat-induced thrombosis. So in 2006, after looking at a myriad of cases, we came up with the definition as well as this classification. So class 1, as you can see, is venous thrombosis to the superficial deep junction, saphenofemoral or saphenopopliteal, but not extending into the deep system. And as you can see by this duplex, the common femoral and the great saphenous vein there without propagation into the deep system. Class 2 is what we've been talking about for the majority of cases. It's into the deep venous system. It's non-occlusive. and thrombus with a cross-sectional diameter of less than 50%. Class 3 into the deep venous system, non-occlusive thrombus, cross-sectional diameter of greater than 50%. And class 4, total occlusion of the involved vein. So what do I worry about? This little area here in a EHIT2. So back then, after looking at all of this material, a lot of my colleagues and I agreed about a suggested paradigm to treat this entity. And if we look at EHIT1, there was no treatment. If we looked at EHIT2, we went to low molecular weight heparin until it transformed into an EHIT1, and then we stopped further treatment. In EHIT3 or EHIT4, we treated with low molecular weight heparin or oral anticoagulants, Coumadin, for 3 months. So that was pretty much the standard as we went forward. So what is the mechanism of endothermal heat-induced thrombosis? Well, it's a forward progression of thermal injury to the vein wall, injury and closure of the superficial epigastric vein, or anatomy in the angle of the superficial axial deep venous interface. What is the spontaneous thrombus versus an endothermal heat-induced thrombosis differ? Well, they usually display a different in terms of echogenicity. And EHIT is certainly echogenic within 24 hours, which is not true of usually a spontaneous thrombus. And propagation in EHIT is rare, whereas that can happen with a spontaneous thrombus. And also the resolution is between 14 and 21 days in EHIT. So where are we now? So if we look at some of the data, this is a study published by Mark Whiteley. You can see that there were 2,400 cases of RFA and 350 EVLA. And he found that EHIT was similar with RFA and EVLA. And the DVT rates compare favorably with those published for saphenous vein stripping. If we move along, we can see another study, vein mapping prior to endovenous catheter ablation of the great saphenous vein predicts risk of endovenous heat-induced thrombosis. And Dr. Lin looked at 312 great saphenous ablations, which 3.2 developed EHIT. Now that's all EHITs, including EHIT1. And so what she understood was reflux in a big diameter of the great saphenous vein at a higher risk of developing EHIT. If we look at this recent study by Kavanaugh and his group, a systematic review and meta-analysis of thrombotic events following endovenous thermal ablation of the great saphenous vein, out of 16,000 patients, including 52 studies, EHIT type 2, 3, and 4 occurred in 1.4% of the cases. DVT events occurred in 1.7% of the cases. PE occurred in 0.1%. So why look for EHIT? And in a publication in 2014 that I published, perioperative duplex ultrasound following endothermal ablation of the saphenous vein, is it worthless? And I concluded yes, and a waste of money. So let's look at it. Many years ago, when we had this entity, we looked at this and either you found it or your ultrasonographer said, hey doc, you've got a clot or a thrombus. And then we'd have to tell our patients, oh my gosh, here's a procedure that we're advocating, and now I've got to put you on blood thinners. And the patients were all alarmed. So what do we know now? Well, the incidence of EHIT in all comers, EHIT 1 through 4, is about 3 to 4%. EHIT 2 is about 1 to 2%. And the incidence of PE by EHIT at most is 0.03%. So are EHITs even dangerous? In a little study that I did, I looked at 9 patients with EHIT 2. All were monitored with serial duplex. 8 out of 9 placed on therapeutic low molecular weight heparin. And 9 out of 9 had resolution of EHIT within 14 days. After resolution of the EHIT, I was able to get a chest CT scan on all of the 9 patients, and 2 of them showed pulmonary embolism. All were asymptomatic. none suffered significant sequelae. So what does this mean? So let's look at thrombus burden. How much thrombus does it take to cause a clinically significant PE? I would submit nobody knows. Is an E-hit2 enough? Probably not. So why look at vein closures immediately postoperative? Because it makes us feel good? We know that the rate of closure is in the high 90s. So let's look at something in a different vein. So if we look at data from 2016, and I would tell you that the 300,000 in the United States is probably greater than 600,000. So let's use a 300,000 and 40,000 in the UK in terms of number of thermal ablations. The incidence of E-hit2, if we take it at high, is of 2%. That means that there are 6,000 cases in the United States and 800 a year in the UK. The incidence of clinically significant PE is about 0.01%, or 30 in the United States, or 4 in the UK. The number of duplexes performed to find one E-hit is simple mathematics, or about 50. The number of duplexes performed to potentially prevent one PE is 10,000. What's the cost of a duplex? Well, the retail price in the United States is $350 to $500. The number of duplex needed to potentially prevent one PE is 10,000. So if you're looking at that number itself, you're looking at a savings of $3.5 to $5 million. If we look at another study done by O'Donnell's group, the cost analysis and implications of routine deep venous thrombosis duplex ultrasound scanning after endovenous ablation, you can see what he did in terms of the numbers needed to screen and the implications. There were 12 randomized controlled trials. There were 19 case series. There were about 14,000 patients with no death. The DVT E-hit is there, 0.0025 versus 0.006 for E-hit. So the number needed to screen is about 2,500 studies for one positive test. And assuming that $100 was the Medicare or government's reimbursement, you're looking at about $12,000. If you look at PE, the numbers needed to screen for one was 10,000 with a $50,000 cost. So he concluded that these data combined with clear significance of E-hits suggest the policy of universal postoperative endovenous ablation screening should be revised. If we look at this last paper by Denis Borsak from Russia, I included it because they did a study looking at treating E-hit with rivaroxaban and thought that there was good outcomes with it. So what's next? Well, a group of us at the American Venous Forum did a paper looking at classification and treatment of endothermal heat-induced thrombosis, recommendations from the American Venous Forum and the Society of Vascular Surgery. Now, unfortunately, it is not in press yet, but it's been submitted, so I have to embargo the data. But here's the methodology. The AVF Guidelines Committee established a writing group to analyze available literature in E-hit to gauge the quality of clinical evidence, to provide guidance on E-hit's diagnosis and treatment. There were 4 subgroups established. 1, to establish the E-hit definition. 2, to discuss the available E-hit classification systems. 3, to evaluate prevention strategies and its risk factors. 4, to appraise treatment options. The methodology was a systematic literature review, 4 scientific repositories to identify potential publications related to E-hit, PubMed and BASE, Cochrane, and Web of Sciences. The following search terms were used: E-hit in patients undergoing RFA and laser ablation, DVT and SVT prior to 2006, truncal veins, great saphenous vein, small saphenous vein, accessory saphenous veins, perforating veins were excluded. There was no restriction regarding language or research design. And the grade system was utilized. If we look at the cabinet classification, great saphenous vein, small saphenous vein, and the Lawrence classification for the great saphenous vein, you can see really that there is a difference in terms of simplicity. This seems to be more simple, but as we look at this, he's divided the class 1 into 2 groups, those that have thrombosed prior to the epigastric vein and those that have thrombosed past the epigastric vein up to the sapheno-femoral junction. And that's the main difference. And the Handler-Locke classification has its own derivation, which is kind of similar to the cabinet classification. So we all decided that it probably would be easier if we put the AVF EHIT classification system together, but I would submit that it's very close to my classification to make it simple and also to be able to use the data for comparison in the future from the past. So unfortunately, guidelines 3.3, treatment for EHIT 2, 3 and 4 are embargoed. But let me share this with you for a moment. If we look at the paradigm for treatment for EHIT, you can see that there's been some changes from 10 years ago. EHIT 1, essentially no treatment. EHIT 2, no treatment. And EHIT 3, no treatment. But if you have to treat, low molecular weight heparin until it disappears in 14 to 21 days. However, EHIT 4, we believe that you should be following the chest guidelines because this is a really rare event and there probably is some underlying thrombotic nature to this. So whether you use low molecular weight heparin, oral anticoagulants like Coumadin, and now with the establishment of DOACs, the DOAC. So ladies and gentlemen, thank you for the privilege. This is a shot from Antarctica that we took a trip just before the lockdown. And at the same time, you can see the moon arising and the sun setting. So that's where we are. We're still in early throes, but the classification from the AVF, as well as the treatment regarding from the SVS as well, I think you'll be able to streamline your treatment and not be as concerned in the future. Thank you very much for the opportunity.
Thank you, Lowell. It was very nice and a very interesting talk. And I think you will get many questions from the floor. I myself am wondering, do you think prophylactic anticoagulation could be an essential part of laser ablation of varicose veins?
So I think that we have to be very careful with that dogma. I think that we need to look at a certain subset of patients that have a predilection for DVT and to be using a guide, either the Caprini score or another score to help you out. But the incidence is so low that the chances in the overutilization of anticoagulation or prophylactic anticoagulation, I think will be abusive except for those high-risk patients. And then the question really is, how long do you anticoagulate? And certainly one day is certainly not enough. And right now, the only literature that's out there to support prophylaxis in terms of anticoagulation for any is in the plastic literature, which is 7 to 10 days, and the orthopedic literature for 30 days. And I would submit to you as an ambulatory procedure that the maximum I would do would be 7 days.
Great, thank you. Before I ask the panel to comment, I would like to thank Survey Company for sponsoring this marvelous webinar meeting. Thank you, Survey. And I will ask Professor Chris Reg from Germany. I think he has to talk, and I think he have a comment. Please, Reg.
Hello, everybody. Hello, Ayman. Hello, Lowell.
Hi.
are there any questions from the audience? Maybe we should hear the questions first, so to give me the chance to include some answers to these questions.
Yes, we will do. But first, do you have a comment for Lowell?
Yes, I have. Maybe you can see my shared screen. Can you see my shared screen?
Yes.
Yes.
That's fine. So, first of all, it's the merit of Lowell and others to give us a good classification of EHIT. Of course, we are all from different backgrounds with different experience, and we are all going for the best in ablation. And concerning this particular anatomical situation, there is the question, how should we treat the saphenofemoral junction? And there is a very, very general set of rules concerning the saphenofemoral junction. All these different rules end up in a single, very, very important commandment, and it is to establish laminar blood flow. If you do so, you will never see any EHIT, no thrombus, and nothing. So it's a fact. We are facing EHIT due to what I call an enormous lack of education, and the danger of EHIT, which is a fact, due to the different levels of education, leads us to choosing what we call a safety distance. But I say it's not a safety distance, it's a coward distance, and it's providing no safety for a good long-term result. And we have to figure out, every one of us, which kind of strategy we are going to choose. And now focusing on the thermal device, we know about the anatomy, and we heard about that in a nice presentation by Erica Mendoza a week ago. And the good question is, how far should we go to the femoral level? And I want to introduce you to very few facts. We did a study on 240 patients comparing closure at femoral level to closing below epigastric vein level. And in almost all the patients, we tried to cover, to close the GSV from femoral level. We succeeded in doing so, almost all these cases. And these are a few examples. This is what we call the ideal laser crossectomy. This image in the middle shows a short stump. At the right side, we see a long stump, which we definitely do not favor. But why? In the 2-year follow-up, we could see that starting the laser from femoral level, we had, after 2 years, 93% of GSV total occlusion without any stump. Well, but when starting a laser below epigastric vein, we just had 89%. So there is a difference. And the difference indicates a higher risk of relapse via the AAGSV. This is just due to the anatomical proximity. So if we leave a distance, we will have a higher rate of AAGSV relapse. That's a fact. Well, on the other hand, EHIT is a fact. And Lovell, you nicely presented your classification, which we all appreciate. On the other hand, people have been doing lots more of lasers than your personal experience. And I think we have done about 50,000 thermal interventions in our European centers, which should be the biggest single center group experience in the world. And we did not know what EHIT is in spite of controls after 1 and 2 weeks. And the difference is how you do thermal insulation. If you know about how to do it, you will be able to protect your deep vein system from thermal effects with an almost 100-degree success rate. And how to do these coaxial perivenous local anesthesia in a so-called no-touch technique without attacking the tissue with a tip, but just with a water beam. This is part of our workshops, and we are eager to show everybody of you how to do this. So my conclusion is, it is clearly not due to any thermal device. It's just due to poor knowledge how to do a proper ablation. And the law which rules everybody of us in our daily practice is we have to go to establish laminar blood flow. The answer is not leave a stump or leave no stump. There are different anatomical relations. For instance, when your epigastric vein enters very proximally, maybe you go for a total occlusion, but if you have, I call it wanted recanalization to maintain the outflow of the epigastric vein, that's fine. This is a laminar flow and no reason for any thrombus formation. Or you can add other techniques. If you're going for a junction like this with a very, very wide opening, you may be obliged to add some internal compression by hyaluronan to adapt the outflow diameter to provide a laminar flow. So I think what you told us, Lowell, is the naked reality, but improving our techniques and including some technology from the future, we may learn more and get rid of this problem and have nice final results. Thanks for listening.
Thank you, Rag. I think you have a good comment. And
I do. I have many. Thank you, Chris, for the lecture. I appreciate it. However, there are many of us that will argue with you in your concepts. Number one, why treat an accessory saphenous vein when it's not broken? Just because you have a 19% or 20% incidence of recurrence, most of those patients are asymptomatic. Number two, you talk about laminar flow. I would submit to you that EHIT 1, 2, and 3 doesn't matter. So why even get into that idea? The reason you go to ground zero is to prevent recurrence and not EHIT. If you do a flush ligation of the saphenous vein, there is an incidence in that small cul-de-sac of a DVT or EHIT, or not EHIT, but you understand what I'm saying. So I appreciate your comments. I appreciate your concerns. And two-method anesthesia, et cetera, and the lessons that you've learned, I think are all important. But is EHIT 1, 2, and 3 really important anymore?
Thank you, Raul. We all agree for that. And I think we have a question from Dr. Ashkan. Dr. Ashkan, you have a comment or a question?
Dr. Ashkan have a question. If we can put him to open his mic.
I'm mute. I'm trying to open my mouth. I was just smiling on both because both of them are right. Actually, I do agree with Chris. Yeah, I do agree with crossectomy. It gives you a good result, but at the same time, I agree with Kapnick because we usually, if they have the accessory, and that goes back again, because I think you both are talking about the same thing. If you have the accessory is competent, so you don't close it, and that means also what Chris tried to say, which is the anatomy, the shape of the junction. So you leave that portion and give it a nick. If you have a good flow from the accessory vein, usually it keeps the flow running, so it doesn't cause the EHIT. EHIT is caused when the flow is stopped, but there's a useless nick, which most of the people was trying to leave from the beginning, and I always was against it. When we close the nick in a place that you don't have the accessory, and it's partially open, that would cause the turbulence, which causes the thrombosis, and that will end up with a EHIT. And all
I have a question for you.
I haven't been a single one. Yep.
I have a question for both Chris and you, and obviously you're a study and a person of Chris, so congratulations. However, you know, when we did high ligation of the saphenous vein, we had neovascularization, which then led to potential recurrence because of frustrated venous drainage. If you go to ground zero, which is what you're advocating, and treating unnecessary accessory saphenous veins to prevent recurrence or an E-hit, I would submit to you down the road, you're going to see the same thing, neovascularization. So Chris, you say no, but you've only been doing ground zero for a bit. Go out 10 years and let me know. And why would, hold it. If you say, wait a minute, Chris, if you say no, why would it be different than a flush ligation of the great saphenous vein?
A flush ligation causes tissue damage, and the neovascularization is a response to injury mechanism, which we saw when we were burning veins in the early experience of lasering 20 years ago. Same with overdose radiofrequency. And since 20 years, or let's say since 18 years, we do not see any neovascularization and any recurrency from the groin using our techniques. That's a fact.
Okay, your fact, there is a 2% incidence of neovascularization in thermal ablation. So that's whether you go to the groin or you don't go to the groin, that's a fact.
If you are talking about the worldwide experience with the majority of non-perfectly educated interventionalists, it will be true. But I'm talking from this research of future methods, and so I'm talking from the optimum, which is not to be generalized, but it's true nevertheless, and we all should go for the best, right?
By the way, is preparing.
I think Dr. Antoniani wants to talk in another point. Dr. Antoniani, what's your comment for Lowell?
Thank you, Lowell, for your presentation. My question is, how many time pass from the treatment and the thrombosis of femoral vein? Is immediate or pass some time?
Could you repeat that question? I'm not sure I understood it.
The appearance of the thrombosis of the femoral vein, how many time appear after the treatment? Immediately?
So within 72 hours, we see them as a rule.
So with immediate control by duplex, it's possible to see the thrombosis immediately and change our treatment. Okay. Thank you.
Okay, great. Dr. Jamal, you have a comment too?
Actually, we tend to routinely, first, great presentations and great comments by both speakers. Thank you. We tend to routinely evaluate the vein, the common femoral vein, at the end of the heat ablation. And if we have any high suspicion that the patient is a high risk for developing DVT to start with, we have been routinely giving them a shot of Lovenox before discharge and for a couple of days until we make sure that they're really very well ambulating. And that has been our approach. Now, it's not as academic as one would like, but this has been our approach, and we have not really seen much of clinical issues with these type of patients. So that's only my comment.
Great. Dr. Oflock, I think you have some instance of thrombosis too.
After the 2012, last 8 years, when we began to use to touring 14, 17 nanometer laser catheters, and then we performed the good quality tumescent anesthesia, we couldn't see any hit until this time. We afraid the large diameter great saphen vein. If the great saphen vein diameter is more than 15 millimeter, we plan to the catheter tip under the junction 2 centimeter below, because in early period we have the experience while using the radial catheter in more than 10 years before. in the normal radial catheter, not through ring, after these very large diameter gray saphen, when we see the thrombosis at the level of the saphenofemoral junction, and we afraid, and then so we began to use this kind of patient at that time, the low molecular heparin. But nowadays, we couldn't see any. But I'm also agreed with my colleagues. There is the new concept, the laser crossectomy. If you have a chance to be a good group, good Doppler technician in the operating theater, so it's a good choice to close the junction very like the flash ligation, especially for the ladies who have the obesity, body mass index is very much, because in our experience, the recanalization in the junction is mostly the obese woman patients. I have no question because the very good lecture, Dr. Kabnik, is thank you very much. And then I think the future randomized and then the prospective studies give the main topics of the EHIT, how we treat, how we follow by the Doppler. Yes, it's a big problem to follow very shorter times. Is the cost effective or not? Thank you very much.
Thank
so
you.
if you would agree that the complications from EHIT are few and rare, and even if you do get a PE, the majority are asymptomatic, I think we're chasing our tail. Whether you go to crossectomy, whether you're 2 centimeters below, you know, the point of the fact is it's a very safe procedure, and this entity of endothermal heat-induced thrombosis, I think we should eventually, I'm going to say forget about it.
Okay, let us start to study this too. And before I leave the mic to Omar, I want to ask Dr. Eduardo from Brazil, what about the EHIT in Brazil? Dr. Eduardo?
Yes, you're asking the wrong guy. I'm a VTE guy. Dr. Kabnik always visits us here in our meetings.
I know that.
Yeah, well, I agree with him. It is, you know, we have an issue with VTE prophylaxis post varicose veins. We still do a lot of stripping here, and we're still seeing some pulmonary embolism. But given the very nature of a heat, number one, I still believe that what colleagues have discussed is what's happening here. So this kind of discussion we have had so many times, Dr. Kabnik, but I totally agree with your position now.
Okay, thank you. Thank you, Eduardo. Finally, Dr. Ul from France, want to ask you, Kabnik.
Yes, I have a remark. Yes, thank you. I have a remark following the talk of Chris. Of course, you can close next to the junction, but you can have good technique to do that. But I think you should have a thinking question is, why do you need that? Because it is regarding anatomy and hemodynamics. Chris told about that. If the epigastric vein is very far or close to the junction, that is one point which could be taken in account. But the most important is pre-terminal reflux. In a case of pre-terminal reflux, in my opinion, I don't know you, but it's not logical, absolutely not logical to close next to the junction. I think it's a mistake because it's not refluxing. You have a normal segment which is working normally. Why do you close it? So, and you remember that half of the patient in situ patient have a pre-terminal reflux. So in this, following this thinking, I think about half of the patient you should leave along the intervalvular segment should be leaved by the endovenous lesion because it's pre-terminal reflux, and in my opinion, it's logical to leave it. What do you think, Lowell, about this?
So I think that you're spot on. in terms of subterminal valve and treating below that with the reflux. And I think Chris has a point as well. You know, if we're talking about absolute perfection of treating this, and I don't think really in reality that EHIT matters anymore. So whether you go up to the junction, but I do think that there is a recurrence rate, certainly not recurrence, but a development or a possible, and I have to ask Dr. Irwin a question. Sometimes all the flow seems to go down the great saphenous vein. And when you take the great saphenous vein out of the equation, then you have the accessory saphenous that's refluxing.
Please let me make a final comment.
Hold on a second, Chris. Hold on, Chris. This is addressed to Dr. Irwin.
Excuse me, Chris. We'll make a special debate for this point. Let's wait for that debate. Now we are talking about EHIT, and we all agreed for the effect of EHIT, and we are taking experience to share experience of EHIT regarding crossectomy. Some agree and some disagree, and please keep it for the debate. Don't burn our debate. Please keep it.
I won't
Dr.
burn
Irwin,
it.
hold on. Chris,
it's
hold on a
just
second.
agreeing to everything anybody of these nice guys says. So the truth is composed of lots of different elements, and we need every opinion to learn together. Thank you, Ayman. Thank you.
Chris, may I ask Dr. Irwin a question based on his ultrasound experience?
Yes, please do.
When you look at the great saphenous vein and its refluxing, is there, or Dr. Uhl, is there any way that you can say that after you close the great saphenous vein or predict that the anterior accessory will reflux, that you haven't missed it to begin with? I guess you could spot occlude it and see if the patient has reflux down the anterior accessory, but you know, we're all talking about even early on when the UIP was at Rome, our early data, Dr. Merchants and mine, showed a 20% incidence of recurrence back then, and we're talking early on in the early 2000s. So it still continues to go on. And the question, though, is, Dr. Irwin, can you actually predict it? Or Dr. Uhl? Or even Chris, can you predict which one is going to happen?
Omar first.
With ultrasound, although a nice question, but with ultrasound, sadly, we cannot predict. I know there are centers that are just intentionally closing the accessory vein because they're, you know, even if it's competent to avoid recurrence. But with duplex ultrasound, we could see large accessory veins which remain competent. And as you know, the accessory vein just enters below the terminal valve, and we like to believe that if the terminal valve is incompetent, that the chance of recurrency would be larger, certainly if the saphenous femoral junction had a large size. But there's no evidence for that, though. There's no paper that will corroborate this theory yet. You know, I mean, if we really wanted to investigate it, we had to target and size it and then map it and then really follow it up. I don't know if Jean-François has any comments on this, because he has done a lot of anatomical studies on this area.
Yes, but no answer for that. No answer for that.
Okay, that's great.
The answer will be given in future by the German Society of Phlebology. We just started a study on this very important question. And I doubt whether we will have a definite outcome, but the answer will be in answering the functional reserve of the AAGSV valves, which have never been looked at so far.
Right.
Great. We are waiting, Chris. Thank you. Now, thank you all. It was very interesting interaction. Thank you. Mr. Kabnik, thank you very much. It was very interesting interacting. Thank you for your patience all. Now I leave the mic for Omar.
Okay, we have plenty of questions as usual to Professor Loyal Kapnick. Let me start with the first question by Dr. Muhammad Rajdan. He said, very informative presentation. Is there any, if you have a concomitant iliac vein compression and renal vein compression, how to decide which is more significant? If it was me, I would say clinical, but what do you say?
I absolutely agree with you from that point of view. And also, you know, we look at SEEP classifications as well as symptomatology. So those patients with, and this is, by the way, controversial as well. C5, C6, there's an absolute hemodynamic issue with those. And if we look at venous hypertension, and then most of us would agree to take care of the obstruction first.
Okay.
If you're looking at C2 disease, never. C3 disease, that's debatable.
Yeah. Okay, second question by Dr. Wasila Taha. Great lecture, Loyal Kabnik. What will be significant differences between E-hit and EN hit?
That is a $128,000 question that we're still wrestling with. I think that what we look at is for foam. I suspect the behavior of foam will look, which could be considered E-fit, could be like E-hit, but we have to watch the data. And then the next question would be on cyanoacrylate. And the cyanoacrylate propagation is threefold. One, it's a combination of cyanoacrylate and thrombus. Two, it's just thrombus. Or three, it's just cyanoacrylate. And in the early studies, when they were doing the procedure first in man, they had a 16% incidence of propagation. They didn't know exactly which combination of the three, but at 6 months, they all disappeared. And the question is, where do they go? So I can't answer that question from cyanoacrylate, but it makes me a little bit nervous.
Okay. Another question by Dr. Ahmed Gawish. He said, great presentation, Professor Loyal Kapnick, about E-hit. We have never had pulmonary emboli from E-hit, but we had post-EVLA shower from thrombosis near leg or thigh perforator. Any difference protocol for these patients?
We have not studied that, but I would submit that, again, we're looking at thrombus burden. And the question is how much thrombus burden. And when you're doing perforators, I would submit, like Chris would, that the technique has to be spot on in terms of that treatment. But I can't answer the question. It's a very good one.
Okay. Another question by Professor Suat Dugansi from Turkey. Dear Loyal, do you think NT caused thrombus is more dangerous or stable than endothelial technique causing E-hit?
Say that, repeat that question again.
Do you think,
the first part?
Yes. Do you think NT caused thrombus is more?
Oh, NT. Okay, I got it. I didn't understand. Non-thermal, non-thrombotic,
non-thrombotic, yes.
Yeah, non-tumescent is more
dangerous or stable than endothelial technique caused E-hit.
So I think it's the same because you're using either foam or you're using glue, and I can't tell you about the glue. But I think that foam has the same kind of historical outcome. There's only one difference, is that you can get thrombus in the deep venous system that's not contiguous with the ablative portion in the saphenous vein. And that, I think, is a different behavior. Although in the early studies, I did exactly have one of those, and the patient refused to go on anticoagulation and came back 3 months later and it was gone. But an N of 1 does not allow me to comment.
Okay. One last question from India. by Dr. Handarabadi. Some people give 2 to 3 firing of laser at saphenofemoral junction. Can that increase incidence of E-hit?
So is it laser or is it radio frequency that they're doing 2 to 3 cycles?
Yeah, some people try laser firing 2-3 times in the proximal part of saphenofemoral junction.
I'm not familiar with that technique. Are they pulling it back and then advancing and pulling it back and advancing? I'm familiar with the RF technique with 2 to 3 cycles, but you know the reality is we're not sure exactly why E-hit occurs. Whether we believe that you know there's this flow dynamics, which I have to agree that there is some of that, but I want to play down E-hit from a thermal point of view, except for those patients that are at high risk, and I think that's a different animal.
Okay, and that's about it. Professor Ayman, Mike is back to you.
Thank you, Omar. Thank you, Lowell. You're always great. It was interesting and a very fantastic presentation and interactive talk. Now I am honored to present my dear friend, Professor Rashad Bishara. Professor Rashad is a senior vascular consultant, and he is the president of Egypt, Africa, Vein and Lymphology Association. He is the founder and previous chairman of vascular surgery department of the Organization of Teaching Hospital and Institutes of Egypt. Dr. Rashad is going to talk about the dark side of May-Turner syndrome. Please, Dr. Rashad.
Thanks, Dr. Ayman and Dr. Muhammad Omar, for the privilege of participating in this webinar. Can you hear me well?
We can hear you well.
Can you hear me okay? Hello? Can you hear me?
There's echo on your mic. There's some echo in the mic. Hello?
There is some echo. I'll start. These are that's Tutankhamun, gold. That's our. These are the pyramids. It may be nice just to take you to a little virtual tour in our beautiful country. Well, the title of my talk is The Dark Side of May-Turner Syndrome. Here is the dark side. It's an example. This is a 29-year-old female presenting with severe edema of the left lower extremity, extending up to the groin of 5 days duration. She was on contraceptive pills. She underwent a Doppler scan, which showed thrombosis of the external iliac and common iliac veins. The decision was taken to undergo thrombolysis, and these are the images. That's total occlusion of the common femoral, external iliac, and common iliac veins.
Dr. Rashad, we don't see the presentation.
You don't see?
We don't see the image of the patient. We just see one image, Egypt, with the colors on it.
No image yet.
Okay, give me a second.
Okay. So I think it will be a great idea. The project Professor Ayman Fakhri is the debate how much from saphenofemoral junction you need endothermal ablation. And I'm very eager to invite Loyal Kabnik and Chris Rugg in this debate, hopefully soon. Professor Rashad is going to restart sharing his screen with his presentation, and I hope everything's work. In the meantime, if any of the panelists have a comment until the lecture started, please go ahead. You can open your mic and go ahead. We're waiting for you, Professor Rashad, when you are ready.
I have a question for Dr. Irwin, if I may. Dr. Irwin, when we look for stenting, we also consider the inflow. In your studies, how can you tell me whether I'm going to have an issue with the inflow for the stent to keep it patent?
That's a great question, Lowell. We're still investigating that. It depends on what kind of machine you have. We're discovering that duplex ultrasound machines are very tricky when it comes to studying inflow. We've had phlebographies being assessed. Even that's tricky. So we're still working on it. It's not a close done case, and even IVUS techniques, we're challenging the IVUS companies to give us more hemodynamic information. So we're working on it. We're not there yet. So it's a bit premature.
Thank you.
Okay. Are you ready, Professor Rashad?
Yeah, can you see my presentation now?
Yes, we can
you
see
hear
the
me?
PowerPoint presentation now.
Okay, can you see the first slide?
We can see the PowerPoint open, but not on the slide mode.
Can you see the first slide?
Yes.
Can you see the first slide now? Can you see now? Hello?
Yes, we can see the first slide now. What about the second slide?
That's the second slide. Can you see the second slide?
No, we only see the title screen.
Yeah, there is something wrong. Well, I'm very sorry about this. Just give me a second. I'll reload the Zoom. It will take me a few seconds.
Okay, no problem. So the mic is back to you, Professor Ayman.
Okay, Omar. Let's have some talks about.
Well, I can take a few questions. I have some questions for Lowell in the meantime.
Yes, this will be great. If you have still questions for Lowell or for Erwin, ask.
Okay, this is a question to Lowell Kabnik from anonymous attendee. He said, "What is the durability of iliac vein stenting regarding long-term patency?" Sure, he means what type of stent do you use as well?
What is the durability of
venous stenting? Yeah, of venous
the durability of it.
Yeah.
So right now, the longest venous stent that we have in the United States, by the way, the wall stent was just approved for venous stenting in the United States, is the wall stent. And the durability seems, in particular cases, seems to be very good. That's a good question for Dr. Raju, who unfortunately is not here. The dedicated venous stents seem to have been engineered for particular areas of the iliac vein and pathology. And I suspect that there will be very good durability with that. How long? I don't know.
I think the American Venous Forum Registry for Venous Stenting by Raju, the 5-year patency rate was something like 85%, which we don't see in arterial stents.
So the patency rates have been really good, especially for the May Thurner. The thrombotics are the ones that tend to be in question and actually lower the overall patency rate. But I think that it's the dedicated venous stents for the thrombotics will be superior.
Okay. Another question to Professor Lowell Kabnik. In case of venous anomaly, do you prefer duplex scan or CTV, and why? It's a bit of a tricky question.
I like both. So it's very helpful to look at a duplex to see if there's arterial as well as venous contribution. And then it's also nice to see the anatomical landmarks as well with the CT scan. So I tend to use both.
Okay. And another question from Dr. Wasila Taha. Great lecture, Professor Lowell Kabnik. Again, she mentioned what is the difference between E-hit and EN-hit, thermal and non-thermal modality, radio frequency, or EVLA versus glue.
So RF and laser, we think are the same in terms of the incidence of E-hit. We're still looking at the cyanide acrylate. The mechanical chemical, again, is the same for us as would be for foam.
Okay.
Dr. Omar, can I have a question for Dr. Kapnick, please?
Please, Dr. Mahmoud Salah, go ahead.
Okay, thank you very much, Dr. Kapnick, for this nice presentation. You mentioned that due to the very low incidence of the EHIT, we don't need routine prophylactic anticoagulation. But you mentioned that some predictors preoperative can predict the occurrence of EHIT or not, like the size of the Saphenous vein or something like that. So you don't even use selective prophylactic anticoagulation?
So I presented one paper on that, and I didn't present the corollary. There are disagreements in the literature about what is the predictive value of size and other attributes. So no, I do not. We do our procedures strictly ambulatory without any unconscious sedation. They come in, they lie down, they get prepped and draped. We do tumescent anesthesia, the usual way of doing it. The patient is discharged about 15 minutes after the procedure. In my private practice, when I was in private practice, we used to have the patient come back 72 hours to look at an ultrasound. And when I went to the University at NYU in New York, my chief of surgery said, you can't have the patient come back in 72 hours. It's $40 here to park, and we've been doing it routinely at a week, and I didn't see any difference. So again, the question is, why do we really need to have duplex ultrasound? And I would tell you post-operatively that it's not necessary. I know in the UK, it's not routine. They predominantly do not see their patients post-op. They go back to the referral source unless there's a problem.
Thank you.
Okay,
Hello.
that's great. I think we are ready for Professor Rashad Bishara.
Yes. So
Okay.
this is the first slide now. I'm very sorry about this mishap. Let's go down to the presentation. Well, I'm going to talk about the dark side of May-Turner syndrome. Well, here is an example of the dark side. That's a 29-year-old female who presented with severe edema of the left lower extremity extending up to the groin of 5 days duration. She was on contraceptive pills. Her duplex ultrasound showed thrombotic occlusion of the left external iliac and common iliac veins. Can you see now the slides?
Yes, we can see it. Yes, very well.
Okay, so we took the decision to go venogram. I'm sorry, for thrombolysis, and that's her initial venogram, which shows total occlusion of the common femoral vein, external iliac vein, and common iliac veins. The thrombus was crossed, and this is the vena cava, which was patent, and she had the thrombolytic catheter placed to cover the whole length of the thrombus. She underwent thrombolytic therapy, and this is the result after thrombolysis. And I would like you to note the large collaterals, which mean that this lady, prior to having acute thrombosis, she had a chronic occlusion. Let's take a look at the proximal common iliac vein. Here is the proximal common iliac vein, which is really nearly totally occluded. And this is another image of the same patient. She was in the prone position. Now she's in the supine. So you see the left common iliac vein on the left side. And here you can see that the common iliac vein, there is no flow really. This is the balloon angioplasty of this lesion. And I would like you to appreciate the tightness of the lesion. It's really a very tight lesion. And this is the result after balloon angioplasty. And there's still a residual stenotic lesion. This was stented, resulting in very good flow into the vena cava. Well, this is an example of iliac vein compression syndrome presenting with acute iliofemoral DVT. Well, this was very well explained by Professor Erwin Tudner earlier on. The iliac vein compression syndrome, which was first described by May and Turner in 1957, and then by Cockett and Thomas in 1965. And it consists in its most common form of compression by the right common iliac artery of the left common iliac vein against the vertebral column. And that's another very nice illustration. That's the right common iliac artery as it crosses from left to right. And it's really compressing the proximal left common iliac vein in this location. Well, this is the most commonly known form of the May-Turner syndrome, but as we heard from Dr. Irwin, there are, and Professor Uhl, of course, there are many other forms of May-Turner syndrome. Well, the question is May-Turner syndrome an anatomical variant, which is asymptomatic, or is it a pathological entity that causes symptoms? This was also shown by Melina Kaibi and her colleagues in 2004, studied 50 consecutive CT scans of patients who presented to the emergency department without having any venous symptoms. And here is what they found. They look at the right common iliac artery here, the vena cava here, and the left common iliac vein here being compressed. And they found that 24% of the patients who had no venous symptoms had 50% or more compression of the left common iliac vein. Remember, those patients were asymptomatic. But the question remains, why do some people remain asymptomatic throughout their life while others become symptomatic, and few of them have very severe acute iliac vein thrombosis? Well, I think the answer is not known, but I could tell you from personal experience that we have duplexed patients 5 and 10 years ago, and then reduplexed them recently. And we found that some patients progress from a normal sized iliac vein, like 5 millimeters or more, to a very tiny left common iliac vein, like 2 millimeters or so. So the condition may actually be a progressive condition in some patients. I don't know why it progresses in some patients and not in others. Well, in an attempt to know the prevalence of May-Turner syndrome in patients presenting with chronic venous disease symptoms, and Neglen in 2006 studied 4,000 patients presenting with symptoms of chronic venous disease. And they found that about 21% of them had thrombotic iliac vein compression. So actually, this pathology is quite prevalent in patients who present with venous symptoms. Well, what are the venous symptoms of May-Turner syndrome? Well, they could vary from little edema at the foot or the ankle to edema of the whole length of the left lower limb up to the groin. And of course, May-Turner syndrome is one important cause of pelvic congestion syndrome. But the most dreaded complication is acute iliofemoral deep venous thrombosis, like this lady. This is a question for you. I would like to know your answers. That's question number 1 in the poll. If you please put the poll. What is the prevalence of May-Turner syndrome patients presenting with acute iliofemoral DVT? Please answer 1 for less than 5%, 2 for 5 to 25%, 3 for 25 to 50%, and 4 to greater than 50. What's the prevalence of May-Turner syndrome in patients presenting with acute iliac vein thrombosis? Few seconds to get the answers.
Please submit your answers. Great.
Okay, the real answer is actually it's greater than 50%. It's somewhere between 50 and 60% of patients presenting with May-Turner syndrome, presenting with acute iliofemoral DVT suffer from iliac vein compression, the type of May-Turner syndrome. It's quite an important number. Now, regarding diagnosis, this has been thoroughly explained by Dr. Irwin. And in this image, you can see the duplex scan, and that's, of course, the left common iliac vein. And that's the left common iliac vein crossing underneath, and you can see a very tiny common iliac vein here. Duplex is our initial study, and for obvious reasons. It's non-invasive, no contrast, no radiation, repeatable. But importantly, as well explained by Dr. Irwin, it's a dynamic study. So you can have the patient in supine or standing or semi-sitting, and you can have the patient in inspiration or in expiration. And that makes a difference in the minimal size of the left common iliac vein. And that's actually very important in decision making regarding whether to do something for the patient, interventional or not. And of course, it's also very important to determine the exact size of the stent. Well, what are the parameters to identify or to diagnose May-Turner syndrome? Nikos Lapropoulos in 2007 suggested that a transverse diameter less than 4 millimeters and the peak vein velocity ratio greater than 2.5 would be suggestive of May-Turner syndrome. Of course, we can use CTV and MRV, which we actually do prior to intervention, but the problem with CTV and MRV, if you look at the cut sections, of course, they are static images. They are performed with the patient supine, and they're performed in 1 second of a time, where you don't know where the patient is actually in or in expiration. And that's a problem, because if you stand up the patient, you might get completely different image. Then the venogram and IVUS, and I'll come to this later, but we don't use venogram and IVUS to make the decision for intervention. We rather use them during or immediately before intervention. And I would like to share with you the second case of iliac vein compression syndrome presenting with this dreaded complication of acute iliofemoral DVT. Again, this is a young lady presenting with short onset of acute thrombosis of her femoral vein and iliac vein, and she underwent thrombolysis. This is the image before thrombolysis, and this is the venogram after thrombolysis, and you can see there is complete lysis of the femoral vein, and if we look at the vein, there is complete lysis, but the flow is very, very slow. We inserted the catheter up to proximal common iliac vein, and this is the image. And you can appreciate how tight the lesion is. It's indeed a very tight lesion. And it required some maneuvers to advance the catheter through the lesion and into the vena cava. And this is the venogram of the cava, which shows a completely normal cava. This lady had an angioplasty, well, a venoplasty, if you like. And again, I would like you to appreciate how tight the lesion is, not only in this place, but it was, again, a little distal, and this is how tight the lesion is, quite a tight lesion. And this is the image following angioplasty. There's still a significant stenosis here, and for which she had a stent with free flow into the vena cava. Now, this is the second question. Catheter thrombolysis, with or without mechanical methods, is controversial. The question is, would you use catheter thrombolysis or other thrombus strategies to treat this patient? Please yes if you catheter directed thrombolysis, or no if you would use only anticoagulation. We'll leave a few seconds to get the answer.
Okay. Keep on, Dr. Rashad, till they finish their answer.
All right, let's see the result of the poll, please. Oh, the great majority of the audience would go ahead with catheter thrombolysis. Well, that's interesting, because of course we are all aware of the recent randomized controlled trials, the most important of which are the CAVENT trial. That's a randomized controlled trial of 209 patients who were randomized into catheter-directed thrombolysis versus anticoagulation. And the patent results at 6 months were in favor of lysis, 65.9% versus 7.4% for the anticoagulation. This was significant. And also, it was in favor for lysis in terms of post-thrombotic syndrome at 24 months. And this result was maintained up to 5 years. Only 41% of the lysis group versus 55% of the anticoagulation group, and this was significant. Then came the ATTRACT trial, which was published in the prestigious New England Journal of Medicine in 2017. There were 692 patients with acute DVT. They were randomized into catheter-directed thrombolysis with or without mechanical methods versus the other group, anticoagulation. And the results were deceiving to everyone. There was no difference at 6 months and 12 and 24 months in the development of post-thrombotic syndrome. But this was regarding any post-thrombotic syndrome. Now, if this group was analyzed for moderate to severe post-thrombotic syndrome, which is really what matters, it was found that there is significant difference, although small, between the lysis group and the anticoagulation group in favor of the lysis group. Then there was the subgroup analysis, which was published by Dr. Kamarota and his colleagues in 2019. They analyzed the subgroup of patients who had iliac vein thrombosis or who had the iliac vein involved in the thrombus. And they found, again, that regarding the moderate to severe post-thrombotic syndrome as an endpoint, this was less frequent group as compared to the anticoagulation group, and this was significant. There has been a lot of criticism to the ATTRACT trial, the most important of which is that they did not include only iliac vein thrombosis, but also popliteal vein thrombosis, a group which we know would not benefit from catheter-directed thrombolysis. But I would like you to look at this figure. Of the subgroup of patients who suffered iliac vein thrombosis, only 39% had a stent, which means that only 39% of the patients who suffered iliac vein thrombosis had significant iliac vein stenosis. Well, it is this subgroup of patients, the subgroup of patients who develop acute thrombosis on top of compression, it is this subgroup of patients who do very poorly if they are put on anticoagulation because they have very slow, if ever, canalization of their iliac veins because compression will always be there. And all of us have seen those patients in our practice. They do indeed very poorly. Well, this subgroup of patients as compared to anticoagulation was never analyzed as a separate subgroup. I would like to go through our very rapidly technical aspects of catheter-directed thrombolysis. I would start with patient selection. This is very important in terms of outcome. While we only do patients who have the iliac vein involved in the thrombus, catheter-directed thrombolysis is not for patients who have femoral or popliteal or cuff vein thrombosis only. It has to be the first episode because if it's a recurrent episode, it's going to be very problematic to get the catheter up to the inferior vena cava. And it has to be less than 14 days because those are the patients who do very well on lysis. The longer the thrombus stay there, the more difficult it's going to be to achieve good results. And the patient has to be of good functional status because patients who are in bed and who don't walk much actually do not develop post-thrombotic syndrome. And finally, there has to be low risk of bleeding. And this is our protocol: ultrasound guided access to the popliteal vein as a rule, into the posterior tibial vein exceptionally if the thrombus goes very distal into the venous tree. Wire crossing test, and this is very important, we advance a wire with or without a catheter up to the inferior vena cava to make sure that the thrombus is actually soft. And a positive wire crossing test would indicate that the thrombus is going to be easy to lyse, while if there is a lot of difficulty in crossing the thrombus, it means the thrombus is old and the results are not going to be very good. Then we determine the extent of the thrombus, in particular, the proximal extent of the thrombus. And then we insert a thrombolytic catheter, and now there is a thrombolytic catheter which can cover the whole length of the thrombus. And then we inject TPA using pulse spray technique every half an hour, and I'll come to this later. And we follow up the patient every 12 hours with duplex scan until we reach the endpoint. Once we reach the endpoint, we take the patient to the cath lab, we do a completion venogram, and if there is a significant stenosis, we go ahead and stent it. These are some photos. That's introduction of the needle, gaining access into the thrombosed popliteal vein. That's advancing the wire into the thrombosed femoral vein. That's advancing the wire up into the common femoral vein, and so on. Could be supported with diagnostic catheter. And that's trying to identify the distal and the proximal extent of the thrombus. In this particular case, the thrombus involved the iliac vein. And then start the thrombolysis. Here is the catheter inside the thrombosed vein. And that's our protocol for lysis. We use TPA, 1 milligram every hour, diluted in 4 cc's of saline. And we inject it in pulse spray technique to achieve this kind of of distribution of the drug, which is very important. We've actually noticed that this type of technique of spraying does produce more rapid thrombosis as compared to simple infusion of the drug. We don't use heparin in therapeutic dose during the thrombolysis. We just use flush heparin to keep things open. And we duplex scan every twice a day. And this is an example of duplex with total thrombosis of the common femoral vein. Again, thrombosis with the catheter and starting to lyse. It's again partial lysis, and that's complete lysis. And once we reach this point with good waveforms, we take the patient to the cath lab and we do a completion venogram to determine whether the patient will need an iliac stent or not. Well, regarding the stent, this is my third question for you. Would you use a stent to treat significant iliac vein compression? Please answer yes for I would use a stent, no for I will not use a stent. Okay, you could see the result of the poll, if you please. Oh, everyone will use stent. That's great. It would be nice to discuss with those who would not use a stent, why not? So I'll just go over the literature regarding the use of a stent. Well, this is a systematic review on the use of deep venous stent for acute venous thrombosis of the lower limb. This is performed by Professor Alan Davis and his colleagues, recently published. Well, it involves all the publications of iliac vein stenting in the setup of acute thrombosis, 27 publications, 542 patients published last year. And these are the results: very good primary patency, excellent secondary patency, few post-thrombotic syndromes, very few stent rethrombosis. And they concluded that venous stenting appears to be an effective adjunct to early thrombus removal strategy. And this is the only randomized control study regarding whether stent or not in the setup of acute thrombosis. It's performed in China and published in the China Medical Journal. 155 patients, 74 with residual iliac vein stenosis. 45 had stents, 29 had no stents. This was a randomized study. While the stenting group did so much better than the no stents, 87.5% patency in the stent group as compared to a dismal 30% patency in the no stent group. And this is another systematic review, which was published 5 years earlier in 2017, by 2,860 patients. Again, technical results is excellent. Major bleeding, very small. Pulmonary embolus, very small. Mortality low. And the results, I think, and AT means acute thrombosis. So these are the results. Stent in acute thrombosis, a very good long-term patency. These are our own results, good technical success, and again, very decent long-term patency. Technical aspects of stenting in the setup of acute thrombosis. I'll touch on the issue of imaging, timing of the stent, and type of stent that could be used. Well, regarding imaging, I think an important issue is the role of IVUS. IVUS is important. This is the video trial, which compared venogram to IVUS, and IVUS identified 81 of 100 lesions, vein stenosis, as compared to venogram, which identified only 50 out of 100 lesions. So obviously, IVUS can identify much more lesions than venogram. And this is an example of IVUS in May-Turner syndrome. For those who are not familiar with the images, this is the very narrow part of the vein. And as we pull the catheter down, the vein is going to become larger in diameter. And here we go, larger in diameter. And it's maybe easier to understand the stat images. If we go from top to bottom, from left to right, the yellow arrow indicates the narrow May-Turner syndrome, and the blue arrow indicates the proximal normal vein and the distal normal vein. IVUS is indeed very helpful in identifying the exact location of the lesion. So helpful to tell us where to put the stent exactly, where is the proximal end and where is the distal end. It's very helpful indeed. Regarding timing of the stent, well, this is the last question for you. What would be the timing of this? When would you deploy the iliac vein stent? Answer: yes, immediately after thrombolysis. No, if it's delayed depending on the patient's symptoms. Would you do it immediately if you find a significant lesion, or would you wait until to see whether the patient is symptomatic or not? All right, let's see the answers, please. Yeah, the great majority, 77%, would do it immediately, and 23% would leave it until to see how the patients would do. Well, our own experience with leaving the patient, in fact, our policy is to do the stent immediately after complete thrombolysis. But again, this is after complete thrombolysis. If we do not achieve complete thrombolysis with very good flow, we will not use a stent because it will thrombose. So after complete successful thrombolysis with complete lysis, and if there is a significant iliac lesion, we would immediately put a stent. And whenever our small experience, actually, it was with patients who refused to have a stent. And those patients, unfortunately, only 2 patients, and they rethrombosed within 1 week. So we would always use a stent immediately after complete thrombolysis. The stent material, wall stent was available for a very long time. It was the only stent available. So there are plenty of studies in the literature describing the results of wall stents for iliac vein stenosis. Recently, there has been dedicated stents for the venous system. And as you may notice, all the dedicated venous stents are made of nitinol. That's for a good reason, because of the natural curvature, the natural angles of the iliac vein. That's external iliac vein, common iliac vein, and vena cava. And there are 2 soft angles, one between the inferior vena cava and the common iliac vein, and the other between the common iliac vein and external iliac vein. Well, nitinol respects these angles, these curves. And that's what all the recent stents have been made of nitinol. We've actually been doing iliac vein stenting long before the manufacturing of dedicated venous stents. And I've personally been using nitinol stents throughout the years. We've been doing iliac vein stenting now for nearly years. And the results of nitinol stents are actually very good. Of course, there has never been a comparison between wall stent and nitinol stents, or between nitinol stents one to each other. Now, post-procedure, just a few words. All the patients 6 months anticoagulation. And then after 6 months, you get a thrombophilia screen, the dimer, they get surveillance, and whether the thrombus was provoked or unprovoked, and we consider significant iliac vein compression as provoked. And we look at the risk of bleeding. And taking all these together, we decide whether we'll go on for anticoagulation indefinitely or not. Well, for a typical case of acute iliofemoral vein thrombosis precipitated by May-Turner syndrome, who had it, and to negative thrombophilia screen and the normal D-dimer and the good duplex surveillance, this patient would go on only for 6 months. And as many of those are young ladies in childbearing. So go on low molecular weight during pregnancy, if they get pregnant. Finally, surveillance. We do duplex surveillance at 1 month, 6 months, 1 year, and then yearly after. And what you can see here is right common iliac arch, which is crossing over the left common iliac vein. You can see the stent, which is very nicely expanding the left common iliac vein and treating the stenosis. Well, here are the take-home messages. May-Turner syndrome is asymptomatic in 24% of the population. So we should not treat a CT showing iliac compression. There is high prevalence in patients with chronic venous symptoms of chronic venous disease. So it's particularly important in patients with severe symptoms such as C5 and C6 venous ulcers. It's detected in 50 to 60% of patients with acute left iliofemoral deep venous thrombosis. So after thrombolysis, we should be prepared for stenting if necessary. Poor spontaneous recanalization of those patients who present with acute iliofemoral vein thrombosis on top of May-Turner syndrome for obvious reasons. Treatment with early thrombus removal and stenting, that's what we do for those patients. And iliac vein stenting for non-thrombotic iliac vein compression has excellent long-term results, as has been shown in nearly all the published results. Thank you very much. I hope the voice was clear and the slide.
Thanks, Dr. Rashad. It was great. Thank you. It was very great and very nice lecture. I think we have a few comments. I think, Dr. Eduardo, we want your comment about the anticoagulation policy after stenting in a thrombotic patient of May-Turner syndrome. What's your policy, Dr. Eduardo?
I think Dr. Eduardo have left. Maybe we can change the same question to Loyal Kapnick. You can open your mic, Loyal.
Would you repeat the question? I was actually answering some of the questions online already.
Okay, I asked about the anticoagulation policy post-stenting in those patients with acute iliofemoral thrombosis in May-Turner syndrome.
We continue them on anticoagulation from the get-go. We tend to use low molecular weight heparin from the get-go for at least 6 weeks. And then we switch over to Coumadin for at least 6 months. And then we reassess then. But there's some evidence that DOACs are okay, except for those patients that have antiphospholipid syndrome. And so that may be better for Coumadin. But there is some suggestion that DOACs are working well, but you have to look at your patient and their response. There is no exact measurement. Everybody has a different treatment schedule. I'd be interested in Dr. Rashad's.
Thank you, Dr. Lowell. May I ask Dr. Mahmoud Salah, what's your policy? Dr. Mahmoud Salah from Saudi Arabia.
I think maybe Dr. Mahmoud Salah is not with us.
Oh, yeah, his mic is turned off. Okay. Now I think let's ask Dr. Antoniani.
Yes, thank you for the presentation. I have a question. Do you have experience with the new direct oral anticoagulants in the treatment of these patients?
Dr. Rashad.
Yeah, sorry, I did. Could you repeat the question?
Do you have experience with the direct oral anticoagulants, the new oral anticoagulants?
Yeah, yes, I think there are no studies to show the role of oral anticoagulants, the new oral anticoagulants after stenting, but I think it's from personal experience, we do put our patients on new oral anticoagulants instead of the old ones, the vitamin K antagonists.
Mm-hmm. Thank you.
Okay, great. I think we don't have more comments from the panel. The mic is now with you, Omar.
Okay, we'll take a few questions. One question from Dr. Wasila Taha to Dr. Professor Rashad Bishara. Her question, how you get a solid parameter less than 14 days from patient history or information provided by duplex? Question to Professor Bishara.
Yeah, I don't understand the question.
She basically said, how do you know that this is an acute thrombosis less than 14 days? Do you rely on duplex criteria or taking patient history to know that it is less than 2 weeks?
Yeah, it's difficult to rely on duplex criteria to know the exact time or thrombus. We rely on the patient history. And then we do the wire crossing test and the catheter crossing test. So if we fire through the thrombus and it doesn't go easily, we know it's an old thrombus.
Okay. Another question from Professor Victor Canata. I think we hope we can bring him to the panelist. He said, excellent lecture, Professor Rashad. Can you tell me the doses of RTPA and how you manage the catheter? This is a question from Victor Canata.
The doses
of RTPA.
Yeah, we have our own special protocol. And if you look at the literature, there is no agreement. There are plenty of protocol in the literature. Our goal is 1 milligram every half an hour using pulse spray technique, and we follow up the patient every 12 hours. Once we reach complete lysis, we stop. And usually we reach complete lysis anywhere from 24 to 48 hours.
Okay. Professor Kanata with us. Do you like to ask anything else, Professor Rashad? Your mic
is was excellent, the lecture, but I was just regarding about how you manage it, because you usually have some kind of bleeding. Do you have patient with bleeding after that trouble? After your treatment?
Bleeding is very rare, and I think the reason is the duration of lysis is 84 to 48 hours. That's one reason. The second reason, we use heparin during the lysis. So careful with patient selection.
Okay.
So we did not have any one case of major bleeding.
Okay. We have another. Yeah. We have another very interesting question from one of the famous venous intervention, Professor Samer Qusayr. I hope we can bring him to the panelists as well. His question to Professor Rashad: how serious is contralateral vein thrombosis from a stent jailing the orifice of the contralateral vein?
Yeah, I think it's a problem. I think with more experience, we'll learn type of stent and which type of what location would precipitate this problem. We didn't see much of this problem because we use 19-volt stents. I'm not sure if the type of stent make a difference, but we did have this problem. Actually, I saw this problem only on a couple of patients, and what we did is lysis of the thrombus and put the patient on anticoagulation, and things went very well. I must say that it does happen, but it's quite infrequent.
Okay, and we can open the mic to Professor Samer Qusayr because he has another couple of questions as well. You can ask them directly.
Thank you, Omar.
Hello, Samer.
Yeah, how you doing? Sorry, guys. Yeah, no, because contralateral DVT, a lot of people talk about it, and to do May-Turner syndrome rate to stent it very well, you have to cross, you have to gel the contralateral, iliac vein. So you have to get your stent all the way to the IVC, unless you use an oblique stent.
Yeah.
So how serious is that? Especially we put the stent in young people who's going to live like 20, 30 years, Is this something really serious, or we have to change the design of the stent, you think? Or what we have, it's fine and enough, and we are getting good results?
My personal impression that it has to do with the type of stent you use. As you said, with most stents, you have to cross to the other side of the IVC and touch the other wall of the IVC with most types of stents, except with the sinus obliquus. I think with more experience, we'll learn which type of stents precipitate this thrombus. But in our experience, it's quite infrequent. So it does not, I would say, it's much more important to get the patient back to normal from an acute thrombotic attack on top of May-Turner than to worry about this infrequent problem.
I think
Okay,
Lloyd
this bring me to the same questions as any rule for kissing stent.
Yeah.
For kissing stents.
Yeah, I mean to decrease that. Is any rule for that, or the thing's too much?
So you're talking about you're talking about a patient who have left iliac vein stenosis and the normal right iliac vein, and you want to put a kissing stent.
Right, to prevent this gelling the contralateral limb. So do you think it needed to be done? Like what we do in the system?
No, I wouldn't agree with this. No.
Okay.
Okay. Loyal Kabnik, do you have a view about the contralateral stenting lying on IVC on the other side?
Yes, I think it's a mistake to touch the wall, contralateral wall of the IVC to gel contralateral. We've shown that, Dr. Raju has shown that, and I think that that is an operator mistake. I think that our present stents, both the Vici stent and the Bard stent, are adequate and do perform well. Of note is that there's an article by Dr. Raju in the Journal of Vascular Surgery, Venous and Lymphatic that was just out, looking at the contralateral limb. Even if that side has an iliac occlusion, he's recommending in his retrospective study not to treat that at the same time because the quality of life seems to improve on that contralateral limb when you do the ipsilateral. So rather than doing kissing stents or however you use, whether you use a Z stent and use that to do both sides, he's recommending that you do one side at a time. And that's a retrospective study and it seems promising.
Okay. I will take a glimpse of overview of the panelists regarding stenting touching the other wall of IVC. Chris Rugg, do you like to add something to this point, Chris?
I fully agree to what Lowell said. It's usually a technical failure to understand the contralateral iliac vein. There might be very few situations where you have the opinion to do it, but you have to go for a better solution and try to avoid that situation.
Okay, Professor Jamal Habballah, do you like to add your comment? Okay. Can you open your mic?
I avoid crossing and touching the other side, and that's my typical approach usually. I had another comment though about the role of IVC filter in these patients and whether the panelists would be inclined to use a temporary IVC filter when using the lysis, especially if the clot extends into the vena cava. And I would appreciate their comments. My practice has been that if the clot extends into the vena cava, I try to put a temporary IVC filter when doing the lysis, while if the clot is limited to the iliac segment and not extending fully into the cava, I avoid doing that. I would appreciate the comments of the panelists.
That's a great question. Let us start by Professor Bishara. What's your opinion?
Yeah, we using pharmacological catheter-directed thrombolysis without mechanical methods. We don't use IVC filters. And if you look at the literature, pulmonary emboli are very rare. But if you use mechanical methods, yeah, I think there is a role for temporary IVC filter.
Okay, Professor Loyal Kabnik?
I agree with the last comment.
Okay, Chris Rugg? Same. Okay, Professor Victor Kanata? Same answer?
I think I don't touch the other one when you are going in that kind of treatment.
Okay, Dr. Erwin, have you seen problem with thrombosis near IVC that warrant to put an IVC stent?
No, in the Netherlands, there's very little use of IVC filters. And just to comment on Lowell's recommendation, not touching the vena cava wall with a stent, I have to disappoint everybody who places stents. There will always be a strut touching the cable wall. It's an illusion that we can place stents so accurately. Even the oblique stent, which has been designed to avoid and to make the perfect, confluence bifurcation, fails miserably. And if you look at ultrasound, I can give you hundreds of images of struts sticking into the cable wall. And do we worry about it? If we're looking at it, we'll probably get like E-hits. We want to fix it as quickly as possible. But we have to be careful with these concepts. So we do jab stents into the cable wall, regardless.
So what is the solution? Because it's very difficult to put the upper end of the venous stent to be far away from IVC wall on the other side. It's not easy.
We're solving a problem, and as long as we don't look for a new one, we're okay. So, but if you want to do a study, we could do this, and we could see how much. A lot of people are getting away with it, and people are resilient. They cope with this. But I think we're making. I have discussions with interventional radiologists who do this quite often. Rick de Graaf, and he was convinced that he was placing these stents perfectly, and I was showing him image after image, as long as you get the right plane, showing that the stent was making contact with some aspect, some part of the cable wall. And should we be worried about it? Maybe in a couple of years when we're seeing wall scarification on the long term. I have a question for Professor Bishara. I'm very curious because you mentioned the two studies, the Calvin and the Attract trial, with regards to PTS, and you used the data to argue whether you should use CDT for acute thrombosis. I think we should be very careful not to use these trials to argue whether you should use these CDTs for acute situations. But the scoring of PTS, and I mean, this is something we're all struggling with. How should we score PTS? What are we using to score PTS?
The question is, the question is, what are we using to score PTS?
Yes. Yes. Do you use C classification or use another classification for PTS?
Yeah. Well, that's a very complex question, as you know, because there are so many so many methods to measure PTS. I mean, like the Villa-Taylor score and the venous severity score and the CF classification and the quality of life score that's related to venous system. So I'd like to return the question to you. What do you use to measure PTS?
Okay.
We're using all these B-class, useless qualifications, the Vil-Alta and all these things, the clinical severity score, and they're not doing a good job. Nobody's talking about venous claudication in all these quality of life forms. So we are trying to build a proper questionnaire, and it's just like the earlier in the evening that was talking about setting up a pelvic congestion syndrome committee. There should actually be a similar situation in trying to define the proper way to score PTS, because we're looking at these public. I saw your presentation, wonderful presentation, but then you show these percentages, and you're saying we're doing a good job with regards to the outcome, and look at this PTS is wonderfully treated. And then I'm really knowing, because I was involved in the CAVA study, and we found ourselves struggling to prove, and actually people were disappointed, saying, you didn't avoid PTS with your CAVA study. Yes, we were struggling to show that the CDT was actually quite effective, like the other studies.
But I would like to my personal experience. If you get a patient, a young patient with acute iliofemoral DVT, and you completely lyse the thrombus, and you put a stent, well, those patients become normal individuals. I mean, they have a completely normal legs, completely normal life. They even, after a few years, they don't come for follow-up. You need to call them and, ask them to come for follow-up. While if the patient have failed lysis or refuses lysis, or he comes too late for lysis, and we follow up these patients, I'm talking about a specific subset of patients with acute iliac vein thrombosis with an underlying lesions. They do indeed very badly, and they have terrible, terrible quality of life. It does not need any scoring or anything. You can see You know, they have very swollen legs, they have prolication. After a few years, they have pigmentation, and then a few years later, they come with a large ulcer that never heals. And then you need to do, you know, to treat them like chronic iliac vein occlusions. You know, some of them we could open up with a stent and so on. So the difference between successful thrombolysis in setup and anticoagulation alone is huge. But I'm talking about a very specific subset of patients. Those are the iliac vein thrombosis with underlying lesions. I think it has never been studied.
Okay, and it's a nice debate. And Loyal Kabnik, you had a comment.
One last question, Omar.
Yes,
I'm sorry.
yes, please.
I just would like to know, just for all the panelists that we have over here, what will be the future of that kind of treatment, the iliac vein stenting? Is safe to do it in an office, or will we have to set up in a hospital environment forever?
Okay, that's a nice point. Let us start by Loyal Kabnik. Do you like to do venous stenting in your office?
So for those patients that are May Thurner, we use a outpatient lab. For those thrombotics, we tend to do it in the hospital for the resources. For acutes, definitely in the hospital. But may I ask a question to Erwin? Thank you.
Please.
Erwin, you mentioned again that the stents touch the contralateral side. I would submit that the vena cava actually flattens depending upon what position and depending upon what hydration. So I certainly agree with you, but I don't think people can be cavalier with jamming that stent to the contralateral side. So when you say it touches the contralateral side, are you seeing it in all projections where the patient's upright, or is it just in a flat supine position that you're seeing it? And what about the hydration?
This is generally in the supine position. It is, you know, as you notice, the body position is extremely important. But if the veins collapse due to the lack of pressure and the hydrostatic pressure disappears, you will see that there's a different dimension. And then, you know, it depends. But you have to realize we're stenting patients. We're talking about DVT arising in a situation that they've gone to an immobile phase and decide that they've been supine for a long period of time. These are the phases that we're looking at. And if you put them upright, they shouldn't.
Thank you.
A lot of patients who are quite active don't develop DVTs. It's in the supine. That's why the argument is to look at patients in a supine position. But you know, you're correct. You're correct. It's a very dynamic process. It's sometimes the wall is there, sometimes it's not. But it's when they're lying down and you can see them breathing, and that wall is scraping past a strut. And you know, what's the significance of this?
Yeah.
You have to wait and see.
Yeah, let me put the question. Have anyone seen problem with stenting touching the other side of IVC that made him to change his clinical decision making? I've seen thrombosis caused from it, but it wasn't treated aggressively. So what do you say to this, Professor Erwin Loyal Kabnik? Have you seen clinical problem from stent touching the other side? We know it's against the guideline. We know it is difficult to implement. We know that if you do duplex scan post-iliac vein stenting, most of them will be touching IVC to some sort or another. A lot of these patients goes well with the anticoagulation. You don't see much of a problem.
So for the May Thurners, it can be a problem. And the only literature that I know of has been Raju's. It's been up to 10%. Of a contralateral occlusion. So, you know, that is a problem. For the people that are thrombotics, well, we're doing the best we can.
Yeah, okay.
I'd like to add a comment. At the time the Raju published this study about 10%, only wall stent was available for iliac vein stenting. And this problem could be specific to this type of stent if it touches the other wall of the IVC. We don't know this.
Yeah. Okay. So I think we took a very nice views of the...
Omar, can I say something?
Ayo, yes, please, Samir.
First, I mean, thank you guys for all the comments, you know. But always we use an IVAS. I'm sure all of you guys use an IVAS during deployment, you know. And if you look, you have to protrude the stent. All the time you see stent protruding to the IVC. I find very hard to really cover the region completely and relieve the compression without the stent protruding to the IVC.
Yeah.
But I agree with a lot of comment that the type of stent make a difference. I'm sure, make a difference. The last thing is that for the IVC, we don't use, for a filter, we don't use a filter, but if you use it, now recently we start using the Capture X, which is like a wall stent, we deployed it and then we remove it right away. We found it's much easier than retrievable IVC filter. So I don't know if any of the panelists has any experience with the Capture X also. Thanks.
Okay, any of the panelists have experience with using Capture X instead of IVC filter? No.
I know that Rick de Graaf believes in it. He uses it often in Germany with Michael Lichtenberg, but they have good experiences with it.
Okay, so thank you very much for the very nice discussion and very nice clinical tips and tricks. So it's back to you, Professor Ayman.
Thank you, Omar. Thank you for you all. I think it was a wonderful evening. We all enjoyed your talks. I would like to thank Survey Company for sponsoring this wonderful seminar. Also, I would like to thank all speakers and panelists for joining Vascular online training program, which is non-profitable program. Thank you, Erwin. Thank you, Kapnik. Thank you, Erwin. Thank you, Lowell. Thank you, Rashad. Thank you all. Thank you, Antoniani. Thank you, Ashkan. Thank you, Jamal. Thank you, Eduardo. Thank you, Ofak. Thank you, Samer. Thank you, Mahmoud. Thank you, Victor. Thank you all. Before I go, I would like to thank Prime Partners for organizing this marvelous evening. And thank you, my dear co-moderator, Omar. Thank you all. See you next Friday with Dr. Olvardo Orego from Chile, Dr. Afak Demiriklik from Turkey, and Dr. Ahmeddin Hussein from Egypt. Thank you and see you next Friday. Please stay safe and goodbye. Bye.
Thank you. Good night. Bye. Bye. Thanks.
Thank you. Goodbye.
Thank you.
Bye.